We are Össur Academy, bringing you virtual learning direct to your desktop or mobile device, wherever you are and whenever you need it. We believe in the value of appropriate and relevant clinical education and have a wide range of learning formats specifically for you. Whether this is for your own CPD, product insight and awareness, or detailed training relevant to your own clinical needs, we provide a huge range of remote learning opportunities specifically tailored to you. We bring together key opinion leaders sharing insights into orthopaedic and prosthetic clinical pathways, our own clinical and professional sales teams offering you detailed product insight and evidence-based education, large-scale secure webinars professionally managed with multimedia content, virtual fittings and user demonstrations offering remote interactive support to colleagues and customers in their own workplace, pre-requested one-to-one virtual meetings with our clinical teams providing real-time diagnostics and support, open meetings allowing for multi-site interaction and knowledge sharing. Contact us now to arrange your own virtual training and education meeting, and visit our website to browse our back catalogue of webinars and other online education events. We are Össur Academy, providing your educational needs.
Good afternoon and welcome to the 8th Surrey Knee Meeting being held live here at Prime Health in Surrey. Welcome, I hope you're all safe and well out there before the impending lockdown. I believe we have over 500 people joining us this evening, so welcome. It's a pretty hectic lineup we have for the next 3 hours. The Össur webinars are normally an hour, but we have 12 speakers this evening over a 3-hour period. And thank you to Mr. Paul Tricker from Surrey Orthopaedics for inviting us, for running the meeting for him. So just before we get going, and so that you're familiar with how to use the system, and I'm sure you're all experts in Zoom, having used it over the last 6 months. But just to go through a couple of housekeeping rules before we get going, to try and make this session as interactive as possible. So you can communicate with us through the Q&A function, and my colleague Giles Lehman will be manning that this evening. Now, there is about 12 or 13 speakers and live patient demonstrations, so please do put your questions into that Q&A function, and at the end of every session, we'll try and get a couple of questions to the speaker. If you do have any other things you want to talk about, then please put it in the chat function. The session will be recorded, and then will be posted onto the Össur Academy YouTube channel, but also the Surrey Orthopaedic media channels as well. You will get an e-certificate for attending, and that will usually be sent out between 24 and 48 hours after this evening, and also follow-up question as well. So you can actually put in what topics you'd like moving forward and how we can improve these webinar formats. So please do make them as interactive as possible. We can go back to front cam. So many different talks and many different speakers this evening. So with that, I'll pass over to our host, Mr. Paul Tricker, who's a consultant knee surgeon at Ashford and St. Peter's, and I hope you enjoy the evening.
Thank you, Stuart. Thank you, everyone. Welcome to Surrey Orthopaedic Clinics here at Prime Health, and thank Prime Health for putting us up this evening. I'd like to thank Össur and Physiolab, our sponsors. I'd like to thank all 12 speakers for giving up their Sundays. Thank you all for joining us on your Sundays, and thanks to the patients for giving up their Sunday evenings as well. So we've got a packed program, and we're going to try and stick to time. So the bios for each speaker are on the Össur website. Hopefully they'll have time to introduce themselves as well. But to kick off, we've got Stuart Butler from Allen Physiotherapy in Guildford. He's a physio to English athletics. He's very passionate about hamstrings, running and ultrasound. And I'll head over straight to Stuart now. Stuart, hi.
Hey gang, I hope it sounds all okay. Thank you for letting me share this with you. Always thanks to Össur for organising, and thank you very much to Paul for inviting us. I know Paul's turned this into a bit of a speed dating session this afternoon, so we'll all try and rattle through with all the best information we can as quickly as we can do. Now, I thought I'd set myself the most impossible question out there. I thought I'd say, how do we prescribe running? And the honest answer is there probably isn't a way to do it. We need to better understand the load and the technical skills that are required, and so that we can more appropriately place the individual under some constraints to improve their maximum efficiency. And a big thought for me is always around that our strength capacity shapes our movement capacity. So there is a great deal of good research that supports strength training in not only in endurance but speed power athletes, and I think it's just something that needs to be considered appropriately. Now, it's all about the individual. This is it depends on their needs, the ability to rehab, the ability to train. It also has a context, and that context can be anything from what the next game is, or when they've got big championships, or it can just be life goals to run marathons for charity or charity 5Ks, as we are doing virtually. So I think I've set myself the impossible challenge. There is no prescription, but if we understand the loads of running, and that's essentially what we're going to talk through today, what changes at different speeds and how to load appropriately, then hopefully inside 12 minutes we can get this done. It always starts with a problem, and the problem should be reverse engineered. So what we want to think about is, what is that athlete's end goal? A elite marathon runner running 2.5 hours for a marathon has a very different load to your charity runner that's going to take 5 hours. And actually the cumulative impact load may well be more on that 5-hour runner than it is on the 2.5-hour runner. We need to examine the physical characteristics. Where do we need strength? Where do we need range? Where do we need neuromuscular control? And we need to look back at that athlete and review what's their injury history. We know the biggest precursor to any injury is a history of previous injury. So we want to look at their training history. Are they new to running? I've seen a lot of what I call hangover patients recently. They've done too much, too soon, too rapidly, normally with a drink they don't normally drink. And that's what lockdown has done to a lot of us. But we need to examine that history and see where we go. And then we actually need to think about the skill characteristics of running. Running is not just something you can do. I love my S&C, and I think if we set 3 sets of 10, we're failing the patient. If we say just run, we're failing that same patient again. I see a lot of this out there, and this is always open for discussion. And I look for that you can start running with these characteristics. I think when we say start running, we should really define what we want, and that will be very, very different for the individual placed in front of us. Some of our elite sprinters running 10 seconds for 100 will take about 43 steps with a rapid contact time of 0.01 of a millisecond. Whereas my footballer or my hockey player might run 8, 10, 12K in a game with 15 to 20 sprints, and probably 2 to 4 of those at near maximum speed. Now we need to increase that capacity. So once we know what the end goal is, Johnny King at Bournemouth Football Club came up with this phrase of, we want chaos theory. If we know the most intense part of the game of football is a 60-second burst with 2 or 3 sprints, 70% effort for that whole period, let's train like that. Let's take players into game scenarios where they work hard for a minute, where they've got 2 or 4 little sprints. Let's rest them up and then let's go back. This is where we can be really creative. Now, if I'm going to guide you towards 2 papers or 2 groups of work, probably Tim Dawn's and Elizabeth Chernov's work is really, really important when we consider what happens at speed. We've got 2 main speeds that I've highlighted, are 3.5 meters per second one and are nearly 9 meters per second. What you'll see from the data is that predominantly when we run slowly, it's more calf dominant, and when we run faster, it becomes more hip dominant. For my interest area, hamstrings, we know that we're creating about 9 times body weight, the same as the ipsilateral hip flexor there, whereas there's very little, only a couple of times body weight through this. And when you actually look around the knee at what rec fem does, even when we're running fast at 8-9 meters a second, we've only got 2.8 3 times body weight there. So the 2 are distinctly different. Going for a jog is distinctly different from running fast. And then we should also consider what changes with age. As I'm no longer 21 years of age, I have to have a little think about this one. Now, essentially with increased age, we get a decreased plantar strength. The faster we run, the higher this deficit gets increased. And the older adult will be more likely to use hip and knee extensors. This may well be poignant when we think around osteoarthritis or specific knee conditions, that the older adult is lacking that plantar flexor strength to potentially offload the knee joint. In my area, I always love to talk about hamstrings, and I love talking about the non-linear relationship between effort and speed. A very grand sentence. It just means you can't jump 60, 70, 80, 90, 100% top speed because the load goes up massively. As we get greater than 85 or 80% speed, we're really increasing the step rate by about 25%. The force goes through the roof to 30%, and the eccentric load on hamstrings goes up to 50% of what it was when we were running at 80% top speed. The example there is with a 75 kg athlete, and we're getting up to nearly 100 kilos of force. Knee joint forces, I thought this was quite interesting. Essentially, we stay around 9 times body weight, whether we're running or sprinting. Again, we probably know that because most of our elite sprinters generate more force from hips and glutes, that the knee joints or the knee kinematics stay very similar. So if we want to overtrain our knee joint, hopping looks like a really worthwhile way. And actually, if we are deliberating over whether to run a sore knee fast or a gentle jog, there's probably very little difference. Again, it will come back to the individual's characteristics. A big area that I'm passionate about are the technical skills. What competencies do we look for? Well, for me, everyone can learn to sprint like a sprinter. It doesn't mean they will in a game or match-based scenario. Carrying a rugby ball, carrying a hockey stick make this very different. But if you kind of learn the rules, you've got the right to bend them. And I thank Stu McMillan for that phrase. But we look for things that the spine and the pelvis are stacked in a nice alignment. We look for a knee lift with a hip flexion. We want to see that you split the front leg and the back leg. That's what we call splitting the thighs, so that we get good triple extension. We still need basic principles, ground contact under the center of mass. Once we're running towards top speed, the vertical impulse, the impulse into the floor, probably matters most and probably creates most speed. We know that with elite sprinters, they hit the ground hardest in the first third of their contact, and they actually hit it a lot harder when we look from a 11-second 100-meter runner to a 10.5 to a 10.0 sprinter. And they're all different beasts. But if we can create some vertical stiffness, we probably are doing the athlete justice. Drills are a great opportunity to practice many different components. This is just a quick mock-up of an A skip, where we've got everything from we can be working on the ground contact, to the lift on the contralateral side, to the arm exchange, to our trunk posture. And we can just use these as part of basic training. These can start early in rehab, just as walking drills, and can progress into dynamic. Resistance training, we know that bone and tendon love load. It's really important to give them that load. I'm a big fan of loading up heavier than body weight. 70% of maximum voluntary contraction helps to increase that stiffness of the tendon and provide some resilience to bony injuries. If we just run on light lifting, we don't see these changes. So we must include a lifting program. For you, with the athlete in front of you, focus on your rehab on the areas of previous injury or areas of weakness, areas of concern. That way you can reverse back. I generally like to use overspeed. If I can get an athlete running faster, especially someone running a 3, 4, 5K, we're going to build that technical competencies and then have some outcomes. The same athlete can have the same 10-meter split time, yet they can do it with very different strategies. So in summary, on my speed day, I'd like you to start with the end goal. Be aware of what speeds and physical characteristics you need for the person in front of you. What are the logical steps that get you there? And what are the key objective markers we can use to do this? Give the athlete skills, empower them, make them be better, show them how to do it. And when working within a team, communicate well, and hopefully everything goes together. Woo!
Stuart, brilliant that was. Thank you very much. Giles, do we have any questions?
There's none currently, but I think it's just a quick whistle stop through.
Giles, I can't hear you, mate.
Okay, Stuart, there's no questions as of yet. Yeah.
Enjoy the rest of it.
Yeah, and you can stay with us for a little while. Brilliant. So next we're going to go to, thank you. Next we're going to go to Lizzie Marlowe. Lizzie is a specialist lower limb physiotherapist working in the NHS and also at Mint Wellbeing in Marylebone in London. She's got special interest in knees and the ankle. And today she's going to talk on ITB, the facts or the friction. Thanks, Lizzie.
Cool. Can you hear me okay?
Yeah, that's fine.
So hello everyone, thank you so much for giving up your Sunday afternoon to join us at this knee meeting, and thank you Paul for inviting me to talk. Also wanted to say a quick thank you to Össur for hosting such a great event as well. So my name is Lizzie Marlowe. I'm a lower limb physio based in London, and I also do some teaching on various lower limb and running courses. So I'm going to be talking to you about ITB today, in particular in a running population. So I'm going to go through 6 common myths and the current evidence and clinical reasoning behind that. So the first myth that I think is common around the ITB is the belief that ITB is the only source of lateral knee pain in runners, and when actually there are a number of different structures, so it's useful to consider this. One being the distal biceps femoris, so it's possible to get a tendinopathy. Patients will generally have more posterior symptoms. They might be worse running uphill or with speed or sprint work, and they might have this classic warm-up pain, so pain that reduces with a warm-up and then may ache afterwards, so a classic feature of tendon pain. In terms of ITB syndrome, it might be more localized to the distal femur. They might have trouble running downhill, so different from a hamstring issue. They might have problems with narrow trails and a history of excessive training volume. So this is a volume rather than a speed injury. And then the lateral patellofemoral joint can also refer to the lateral knee. So patients will generally report problems with loaded knee flexion, stairs, and prolonged sitting. Degenerative meniscal pathology is also a common source of lateral knee pain, or perhaps some early compartment OA. So patients are generally over 40, have problems with hard surfaces, perhaps some twisting, and they might even be a little bit stiff in the morning. Don't forget specific bone pathologies like a bone stress injury or spontaneous osteonecrosis of the femur. And these patients, their symptoms are going to be a bit more diffuse. They might even have some night pain, some trouble weight bearing, even a bit of swelling, and possible risk factors for metabolic bone issues. And the REDS clinical assessment tool would be useful there. And finally, don't forget common peroneal nerve entrapments and lumbar radiculopathies, both of which can refer to the lateral knee. Patients generally report vague distribution of symptoms. It's quite unpredictable. They might have some burning, some paresthesia, and even some night pain. So don't assume that all lateral knee pain in runners is from the ITB. Myth 2 would be probably that ITB syndrome is caused by friction or rubbing over the bursa. So you can see that in the video here. There's a video of sort of a small, an ITB flicking over the lateral femoral condyle. So this is anatomically incorrect. So there's some nice studies to support this. We know that the ITB is a lateral thickening of the fascia lata of the thigh. So you can see that here. And the fascia lata extends all the way around the whole diameter of the thigh. And it's a complex layered arrangement of tissues with multiple attachments and connections. So it's not a thin wispy band that flicks over the lateral femoral condyle. Underneath is a highly vascularized and richly innervated fat pad, and there is no bursa underneath the ITB. So if we assume the bursa is there to reduce friction, if there's no bursa, that might support that this is not a friction syndrome. There's another study that further supports this. So the ITB is actually firmly anchored to the distal femur via Kaplan fibers, which are strong oblique fibrous strands that actually anchor the ITB to the distal femur and prevent friction or rubbing over the distal femur. So it's suggested that the ITB fibers are actually tensioned in sequence from anterior to posterior, and that peak compression occurs at around 30 degrees of knee flexion. So this compresses the intervening fat pad, and repeated or chronic compression is suggested to trigger a chemical inflammation in the flat pad. So it's the fat pad that's thought to be the pain generator rather than the ITB itself. So I think the jury's still out. We can't confidently say that it's not a friction syndrome, but there's certainly enough evidence out there to suggest to me that it would be more of a compression pathology. Myth 3 would be that ITB syndrome is caused by a tight ITB. So we know that the ITB is a relatively inextensible band of tissue, and it doesn't undergo any significant length changes. I don't believe that it gets particularly tight with certain activities. We do know that the TFL and the glute max attach onto the ITB, and so overactivity or tightness in these muscles could potentially influence the distal attachment onto the patella or the Gerdy's tubercle, but this probably isn't relevant for all patients. So let's look at the particular subgroups. The most common on the left would be the female who collapses into a bit of dynamic knee valgus. She's got a contralateral pelvic drop, a bit of femoral adduction, and possibly some tibial internal rotation. So these patients are much more likely to be lengthened rather than tight in their ITB. And you can see how this particular movement pattern would increase compressive load of the fat pad underneath the ITB. The other subgroup would be possibly more likely in males, and they have this varus knee with possibly some slight acetabular retroversion, and some of these might be tight in those lateral hip and knee structures, and this could contribute to ITB syndrome and development of ITB syndrome, but it's certainly not relevant for every patient. If we think about the causes, I think you can separate them into biomechanical, neuromuscular, and training errors. So we know in terms of biomechanics that there's this impingement zone that occurs at around 30 degrees of flexion, and this is worse as the hip extends when there's eccentric load going through the TFL. So if you look at this runner on the left, as they're going downhill, the hip is extending as the knee's flexing, and that's when compressive loads are high. This is also exacerbated by things like a narrow step width or a crossover gait and a varus knee, as previously mentioned. In terms of neuromuscular factors, things like gluteal strength or lack of gluteal strength or endurance, or poor control, so poor control of tibial internal rotation or femoral adduction can also be relevant. I think this is the area that's commonly overlooked, and that's training errors. So we know that training errors account for about 80% of running related injuries, and people often fail to think about this. We're very focused on the biomechanics and the structure, but it's really important to consider the influence of training volume, downhill running puts particular demand through the ITB, stair descent, and trail running. So running on a narrow trail can increase strain at the ITB. So myth 4 would be that Ober's test is a useful test for detecting ITB tightness. This is a really interesting anatomical study. They looked at the Ober's test in a series of cadavers. They did an Ober's test before and after transecting the ITB, and they found that there was no significant change in outcome after complete transection of the ITB. They found actually that the more significant contributors to a positive Ober's test were the hip joint capsule and the lateral glute. So this has questionable validity when we're trying to think about whether or not this detects ITB tightness. Myth 5 is that stretching and foam rolling the ITB is an effective treatment for ITB syndrome. So we know that not all of these patients are going to be tight laterally, and we know that the ITB is inextensible, but I still see multiple patients going through an extended program of stretches and soft tissue techniques. If we think about the causes, this just isn't going to be sufficient, and we need to stop using a one-size-fits-all approach to these patients. We know that from fairly recent biomechanical work that the ITB is inextensible, it can withstand substantial tensile forces. Stretching and foam rolling does not result in significant lasting tissue change, and some of these techniques may even increase local compression, so exacerbate the symptoms. And the final myth, so myth 6, is that it's all in the glutes. So absolutely, I think that glute strengthening can be very relevant for certain patients, but certainly not everyone. So if you think about the classic example of a male runner, he's fairly strong, he's suddenly ramped up his training, perhaps he's training for a marathon, he's started doing increasing his volume and doing some downhill running. If you put him through an extensive gluteal strengthening program without addressing the training errors, then you're going to be doing him a significant disservice, and it's unsurprising that he won't be getting better. So we need to think about these 3 pillars again. So addressing biomechanics, so things like increasing step width, increasing cadence, and reducing dynamic knee valgus have all been shown to reduce peak strain on the ITB. So these are useful, simple things that you can do in clinic with patients. Addressing neuromuscular deficits, so we've already talked about improving strength and dynamic control. We know that this doesn't correlate to a change in running mechanics, but it can be a useful way of optimizing sort of load capacity and tolerance to load. And then the final one is addressing training errors. So this is absolutely vital. So in the early stages, it's important to reduce training volume, reduce downhill running, and things like reducing trail running and stair descent. And you might even want to start them on a controlled uphill running program, because this reduces the compressive demand on that fat pad. So in summary, lateral knee pain is not always ITB, so your history is absolutely crucial in giving you subtle clues about your potential differential diagnoses. There's a questionable role of friction in the etiology of ITB syndrome, so I'd encourage you to think about it as a compression syndrome. The causes of ITB are often complex and multifactorial, and probably a result of a combination of intrinsic and extrinsic factors. So it's more than just a tight ITB or weakness in the glutes. OBERS is not a valid test for ITB tightness. Stretching and foam rolling the ITB is not an effective treatment, but there are probably a subgroup of patients that will respond well to some soft tissue techniques to the lateral, so the TFL, the glute max, and the vastus lateralis. But that's in combination with a multifactorial program. And then finally, glute strengthening is not always necessary for these patients, but a large proportion of them will do quite well with a glute strengthening program. Okay, so that's the end of my talk. Thank you so much for listening. Feel free to ask some questions in the chat box, but if you want to send me any messages afterwards, my Twitter is @emarlo89, so feel free to message me then as well.
Hi, Lizzie. There's a first question, perhaps to do with COVID and the fact that we're having to do a lot of virtual assessments, but is there any way to identify initial stage ITB at home, perhaps? Do you have any experience with that?
Identifying initial stage of ITB at home? Yeah, so I think the history is absolutely vital. So the pain location, so it's very localized to the lateral condyle of the femur, and they very, very often have had a sudden ramp in training, so they will have increased their running distance, and they might really struggle with things like downhill running. So for me, the history is absolutely crucial. In terms of the clinical tests, there aren't really any well-validated tests. There's a Nobles test, which you could look up, which you could do over video, and that essentially asks them to do a single leg squat, and it might reproduce their symptoms at about 30 degrees of knee flexion, which we know is when the compressive loads are highest. And so yeah, I would say the history is absolutely crucial for me.
Lizzie, hi, Paul here. Brilliant talk, thank you. I was just about to say single leg squats about as good as we can get, and thank you for removing OBERS test from my clinical demonstration later. What about the role of injections and the role of surgery?
I'm sorry, I can't hear you, Paul. You've just suddenly gone really quiet.
Muted myself. Can you hear me now?
There we go. I can hear you now.
Okay, so when an ITB patient comes to you with clear ITB friction, yep, MRIs excluded the meniscus, good history, what do you say to them in terms of how long, Lizzie, am I going to be able to go back and run, you know? Because this is not a sprint rehab, is it? It's more a marathon. It's going to take time.
Yeah, I think it depends on the patient and the length of symptoms. So if it's a fairly acute onset and we can sort of get on top of it quite quickly, I would expect them to see some improvement, certainly in the first 4 to 6 weeks. But it depends whether or not they're willing to reduce their training. I think with runners, they classically don't want to give up running. They classically find it really hard to make any sort of adjustments to their training schedule. So I think everyone's very, very individual and unique. But I guess if they're on board with the idea of making adjustments, I would definitely expect to see them improve within 6 weeks.
Okay, and a couple of other questions, maybe from a surgical bias. What do you see the role of injection therapy?
I think that's probably more a question for you, Paul, but I think if they've got night pain and sort of very irritable symptoms and they absolutely can't do an exercise program, or they're really struggling to run, then I think there would be a potential role for an injection there, which can give good buy-in. But I'd love to know your thoughts on that.
Yes, I'm happy to give an injection if they are still struggling with rehab, but they always have rehab first, because an injection can just get them back running, and maybe that's the worst thing to do at the time. And the final question I'll ask you quickly is, do you ever send patients for surgery for ITB?
I have never sent a patient for surgery. I think generally they do pretty well with some really sort of simple adjustments to their training and possibly their running technique, and just knowing kind of the right exercises at the right time. So no, I haven't, but I know there are some surgeons that operate with very good success. So it's not that I'm completely writing it off. It's just not something that I would do.
No, fine. And that's my practice as well. Very few go to surgery, probably 5 out of every 100. And most of those are actually physiotherapists. I don't know why, but maybe because the rehab's quite hard. Lizzie, thank you very much. And thanks for giving up your Sunday.
Thank you for having me.
You're welcome. Next is Jill Newey, who is a local physiotherapist here in Weybridge. She's done lots of Ironmans, marathons, triathlete. She's also had an ACL reconstruction, and no one rehabbed quicker than her. And she, in an age where we're talking about shared decision making, how do we get the message through to our patients, and how do we make sure they understand? Jill.
Hi, I'm Jill Newey. I'm talking today about getting your patients on board in terms of education. It's obviously a really important aspect of treatment, and one that we all do, obviously, but sorry, I'm just battling with this to get it to move. Oh, there we go. Okay, right, so it's something we all do. It's something that some of us do better than others, and I've got so many tips in the past from other physios. So I just thought I'll share the love today and just share some of my most common ones that I use. I think to keep it simple is the best piece of advice I can give, and use pictures and analogies. Okay, so I always start with knee patients describing the role of their pelvic and core stability and hip stability. With the knees, I use a construction crane normally as an analogy. And I want to just say, look, construction crane, it's huge, you know, it's long, it lifts big loads. If it's not anchored down at the bottom with big concrete blocks, it can't lift the big loads. And it'll be all over the place. So education for patients will be, if the pelvis and hip are all over the place, the knee will be too. Okay, so and this is one for my OA patients and post-op. When they ask me, you know, why is it so important my knee goes exactly straight? Well, there is a reason. So when you're standing, if you've lost the lockout in your knee, your quads will always be contracting, which means your kneecap will always be under tension, which means that will accelerate the wear and tear. And also, when you look at the contact force, you know, you're not on the flat part of the femoral condyle, you're on the really curved part. Okay, there's a much bigger increase in pressure there, and that can wear away articular cartilage and meniscus as well. So take-home message for patients is full extension is really, really important in the knee. My favorite exercise is probably oven gloving, which is where, you know, just ask patients to stick the leg up on a stool, make sure as much of their leg is exposed as possible, just to increase the effects. Stick a bottle of wine in there, some dumbbells, they must relax. A lot of patients say it just feels like their knees hyperextending. It's not, it's just the effusion making them feel like it is. So just reassure them, ask them to totally relax, make the knee feel vulnerable, and oven gloving works quite well. It's sort of low load, long duration. Okay, why is loss of flexion a problem? People ask, you know, missing 10 degrees, why is that an issue? It's not immediately an issue, but it is long term. So when your knee doesn't bend fully, you start to get a bit of tightening of the retinaculum and the quads. So over time, that leads to accelerated PFJ wear and tear just through the increased tension. So yeah, take home message, get your knee moving fully and symmetrically. All right, so this is for your very irritable patellofemoral patients. You know, that question of why does my knee get so stiff and sore if I've been sitting for a while? So I just always explain as an analogy of a rope going over a cliff edge, and just that contact point of the rope at the edge of the cliff, you know, that'll increase with increased tension or increase the heaviness of the load that rope's carrying. So I say, you know, if your quads are really tight, that tension increases. And obviously as your knee bends, it's got to go around a corner. Okay, so that's why this elastic then pulls tight. So that bowstrings the kneecap back, and boom, you've got a problem at the back. So I always educate my patients on how to rest an extension, offload the kneecap, just get it settled down before we start any sustained or positions or repetitive loaded knee flexion. Okay, so this one's a bit brutal, but I call it the cheese grater analogy. So this is what I use for explaining to patients, A, why they need to get their quads to loosen up, and B, if they want to do things like squats. So I say, right, imagine you've got a cheese grater against your skin. If your quads are quite tight, it means you push that cheese grater harder into your skin. If you're doing a dynamic squat, it's then moving that cheese grater up and down. Whereas if you choose to do a static squat, it's sort of pushing the cheese grater in, but holding it in place, which is a lot less traumatic to you than moving it up and down. And the looser you get your quads, the less pushing there is on that cheese grater. So patients tend to understand that one quite well, even though it is quite a brutal analogy. Okay, so then my PFJ patients, most of them will get cycling. So the main aim with cycling is to minimize force through the kneecap. And I like cycling the best because your body weight's taken by the saddle. People don't tend to get that. So explain to them, look, your body weight's being taken by the saddle. You want to reduce their knee flexion angle at that most bent point. So high saddle, drop their heels. As soon as you drop your heels, your knee flexion angle opens, high cadence of 80, and this makes sure that their resistance is not too high because all bikes differ with their resistance. And I always say scrape poo off your shoe. Okay, so just really get the hamstrings functioning. Hamstrings don't work via the kneecap. So push their hamstring function and just minimize forces through the kneecap. All right, so this is what I work with the most. Excessive habitual knee rotation. Patients do it all the time and they don't realize that the twist is happening at their knee, okay, not at the ankle or the foot. And if patients present with laxity like this and they do it habitually all the time, I guarantee you they have closed chain valgus as well, going downstairs and things. So I always I take photographs of patients doing stuff like this and I send it to them. Okay, so they get a little bit of increased awareness as to what's going on. Now, why is it a problem? So I use the mortar and pestle analogy. So if your knee's constantly doing this all the time, you're just grinding away at that meniscus. And your kneecap, of course, is well, your kneecap's not moving, but the groove is moving all the time. Okay, all the kneecap is if the tibia is moving, if the femur is moving, it's the trochlea. So the mortar and pestle effect works quite well as well to scare patients from not moving badly. All right, so where do I see rotation the most? Things like stairs. So often I will ask a patient as a visual reminder, so they actually do it all the time, is to just take a line down their stairs, think about their big toe as a laser pointer, keeping that laser pointing forward all the time. So you don't want it to go out as they go up the stairs. So use visual guides. That's a really good way to get patients on board. Another one that patients typically think, they think hip width apart is at the greater tuberosities. So they normally always stand too wide when we're doing alignment work. So I normally tell them, just think about a gap of a fist between their feet, and that normally sorts them out. The wheel analogy I use a lot as well. This is for explaining varus and valgus and why they get lateral or medial compartment wear. If a wheel's not aligned, you'll wear out the rubber on one side. So the goal is to shift the load onto the less worn part. Right, kneecap in line with the second toe. A lot of patients get this wrong. They come in, they demonstrate their single leg squat or whatever they're doing down the stairs. And they say, oh, look, I'm in the line because my kneecap's in line with the second toe. And clearly they're not. So what I tend to do is I use 4 points of alignment. So the hip needs to be included in all of this. So I always tell patients to try and get these 4 dots in line vertically as much as possible. Obviously, not everyone will be able to get it right, but at least it starts to include the hip as well. So yeah, if you're using video analysis, it's quite an easy thing to do. So you just extrapolate a vertical line up from the heel and just see how much of that alignment they can get through the dots. Okay, and then obviously we can't help everyone. When patients have been doing this for a long, long time, their knee becomes molded to a sort of a valgus shape. This is a typical patient like this. So her right knee is like this because she's played hockey all her life, and she used to just stand in a split stance with her right knee in rotation all the time. So she's got a structural change now. She's too old to change it. So she gets an unloader, okay, to try and shift the load from the lateral compartment to the medial compartment. So the take-home message there is to brace if you cannot get their alignment right. All right, and then I talk a lot about remolding the knee. This is more for the younger patients, and ones you can see they're heading towards the OA in one of their compartments. So I tend to do thousands of reps in controlled alignment with the weight unloaded to start. So bike, get them on the ergo, the slider, or you just use a skateboard at home. Just lots and lots of backwards and forwards with the pelvis anchored, the foot anchored. All they have to focus on is their knee, just to get the knee surfaces used to rolling in a different way. And I always say, if it doesn't feel different, you're not changing anything. So it has to feel different. It will change with time, but that's my take-home message for them. All right, that was a big rush, but I think that's it. Thank you for listening.
That's really good, Jill. Can you hear me?
Yeah.
Okay, Jill, look, we're going to move on in the interest of time, but everybody, Jill will stay with us and answer any questions through the Q&A function. Okay, so next we are going to Ben Steele-Turner, physionutrition, who's dual trained, first class honours in his BSc in physiotherapy. He's committed to a holistic approach in rehabilitation. Alongside physiotherapy, Ben's also a nutritionist, having gained a master's with distinction in human nutrition, and he's an ex-fitness model as well. So Ben, thank you.
Hi everyone, can you hear and see my screen?
Yes, we can.
Hello, awesome. So thank you so much for joining us on a Sunday. I'll make a start. My name's Ben. I'm an MSK physio and also an associate nutritionist. I work at Cranfold Physical Therapy Centre right here in Surrey. So I'm really, really passionate about how physiotherapy and nutrition can cross over and how they can mutually help each other. And today we're going to take a little bit of a uber quick explore into particularly for knee health and clinical progression of osteoarthritis. So you might be thinking, am I sharing my screen? Look, I am sharing my screen. Am I not sharing it? I'm not sharing the screen. Okay, sorry about that. Right. Okay, let's go back. Okay, can everyone now see my screen? Yeah, sorry about that. So what are we going to do for osteoarthritis of the knee? Apologies about that. This is the only slide you would have missed. So you might be thinking, what is Ben talking about nutrition at a knee talk? But if we boil it right down to the basics and look at an umbrella, all that strengthening work we're doing for our osteoarthritis patients, if we are not getting enough protein, the muscle mass isn't going to be as beneficial. Systemic inflammation is hugely linked to what we're eating, and then also, of course, with the progression of OA at the knee joint in particular. Micronutrients, any particular deficiency will impact OA progression. And the main one, a high BMI, overweight or obesity, increased adipose cytokines, abnormal loading patterns. Vitamin D gets an awful lot of attention, and maybe that's justified. And then also the ratio of dietary fats is going to be crucial as well. So if we look at and take a little archery analogy, what you see in the center are the three core principles, and these are taken from the NICE guidance for OA management. So education, advice, and information. We're probably hitting the arrow on this one, generally speaking as a physiotherapist, strengthening and aerobic training. And then dependent on our specialty, everything on the target's valid. We can hit our arrows where we like, and this is all great. But the arrow that's meant for weight loss support where needed and dietary help, I think quite often is missed, and it's definitely a chance for a bullseye that we're not getting. So the impact of adiposity, if we add obesity to this OA knee, we get abnormal joint loading, but then we also get this low-grade inflammation, which is going to accelerate OA progression. This was shown in a large cohort in the Netherlands, where they found that a link between waist to hip ratio and hand OA was linked. So there was a non-mechanical link, and particularly visceral fat, which we know is more metabolically active. There's also, it's a strong independent risk factor. So if you've got high BMI at the time of knee OA diagnosis, this is a real big sign that you might need to go on to have a joint replacement. So let's take a real quick look. How is this all actually going to help and hopefully inspire and start this conversation? So improving body composition should be an initial focus of treatment. And in this cohort, 240 knee OA patients, mean age of 65, they did an 18-month intervention. And this intervention was a structured diet and exercise plan. And effectively what the results boil down to is this dose response relationship. So they grouped them into whether they achieved 10, 20% or less than 5% body weight loss. And there was this huge benefit. And generally we want to be initially looking at a 10% loss, at least for knee OA patients who are overweight or obese. Dietary fats confuse me a lot. They confuse everyone. So I've designed a little family tree, and this is going to hopefully help explain, so we can go from there. So we've got saturates and unsaturated fats. Saturated fats we're very commonly told to avoid. And then unsaturated, we could split into polyunsaturates and monounsaturated fats. Monounsaturated fats don't get as much attention, but omega-7s and 9s are crucially important for human health and for the knee. and then omega-3s and 6s. 6s generally from nuts and seeds in various ratios, and then also from animal products such as eggs and meat. Omega-3s, again, nuts and seeds in different ratios, but mainly from seafood products. And in both for general health, but also in relation to the knee, omega-3s, omega-7s and 9s, we want to be prioritizing these. And omega-6s, we're going to get a lot, but generally in the Western diet, these are eaten in quite a high amount. So we'll take a look at this 2-year RCT into omega-3s. So the first group were given 4.5 grams a day EPA and DHA. This is a very, very high dose. While the second group were given a low dose per day. And this would be 0.45 grams, which is more kind of like a standard fish oil kind of usual supplement amount. Both improved in the 2 years, and you'll notice on the charts here that it was after 3 months, they saw a significant improvement, and then that was generally maintained over the 2 years. But actually the low dose group saw slightly better results. And what I think here that really proves that the ratios are important, and also one of the ingredients in the low dose pill was actually a monounsaturated fat. But what I think is a real key piece of evidence in this is you'll notice there's a lack of a control group, and they actually didn't get ethical approval to prevent a group of patients of this age from not taking an omega-3 supplement or from advising them against a low omega-3 diet. So that's quite important, both for knee health and for overall health as well. Dietary protein, we clearly know sarcopenia and loss of muscle mass as we age, but muscle is pivotally important to the knee function, and strengthening is one of the core principles which we generally do really well. So we're spending a lot of time doing all these exercises, but then if that patient week by week, month to month is only getting 50% of the dietary protein they actually need, then simply by giving them the advice, making sure they're getting enough dietary protein should augment the current treatment at this point. Micronutrients, vitamin D, all over the news, and it really has a large range and variety of roles. A major role, though, would be for us regulation of bone metabolism and mineral homeostasis, and it's also really important for optimal muscle function. So the results from human studies are generally mixed. It's quite hard, but they suggest this positive association between our vitamin D status and reduced OA progression, so slowing it down. Now, these are difficult to interpret because what seems really important is maintaining our vitamin D status throughout our life course. So it's very difficult to come in as a researcher, put an intervention of vitamin D in, and then suddenly see improvements. So this analysis of a cohort of 413 knee OA patients probably demonstrated this the best. They classified these patients over the 24 months into 3 groups. So there was the consistently insufficient group. So these are all knee OA patients, and throughout the 2 years, at no point did they have a high enough vitamin D status. The fluctuating group, who at some points had enough, some points they didn't have enough, and then the consistently sufficient group. And unsurprisingly, consistently sufficient, they saw beneficial impacts on their knee health and delayed OA progression. So recommendations for vitamin D, summer months, sun exposure should be enough. A 10 microgram supplement should be strongly considered. And also another reason to maintain a healthy body composition is vitamin D can be sequestered, so it can be hidden in body fat. And so if we lower our body fat percentage, more vitamin D becomes available, and that's gonna help out for sure. Last of all, for this little quick dive into the world of nutrition in the knee, vitamin K, which is very, very common in green leafy plant foods, as seen by the bit of broccoli, heavily involved with bone and mineralization, bone and cartilage mineralization, sorry. Current evidence is generally, as with a lot of nutrition, very observational. So we can't clearly demonstrate this causality, but there's a real strong agreement that sufficient vitamin K is associated with reduced OA progression. Now, in 2002, the National Diet and Nutrition Survey looked at what proportion of UK adults were not regularly getting enough vitamin K, and they came to the answer of 59%, which is quite high. And then later in 2016, a repeat of this rolling program found that only 31% of UK adults were achieving their 5-a-day target. So we really want to be encouraging our patients to eat plenty of green vegetables. And also another reason to get our omega-3s, olive oil and other oils, increase the absorption of vitamin K, so they make it more useful, more bioavailable. So, in summary, for physiotherapy and all musculoskeletal care for a knee osteoarthritis, for a lot of patients, a good planned nutrition intervention would be a good way at positively modifying knee OA symptoms. Of course, with all forms of healthcare, this has to be tailored and it's got to be adapted to the individual. Knowing our scope of practice, so who and when we need to refer to, and obviously it's not suitable for all, so it should be considered more, but not as a blanket statement. So anyway, thank you so much for listening. Apologies for not sharing my screen for the first few seconds. If you have any questions that don't get through now, my email, my phone, my Instagram is on there @physionutrition. Absolutely, feel free to contact me. I'd love to start a conversation with you all. Thank you so much for listening, and look forward to the rest of the evening.
Thank you, Ben. There's one question first of all, just saying that they always, it's a question from Juliet Arthur, they always mention weight management in OA knees. In the current climate with no weight management classes being held for those patients with high BMI, do you have any resources that you refer to support them?
Generally, it needs to be tailored. I'm not routinely going to one source to recommend. That would have to be something you would talk to the person about through a virtual consultation. Otherwise, we're just giving them the blanket information rather than help facilitating it to that individual. So I'd say discuss it on a one-to-one basis and work out how the diet's going to help them specifically.
Great, thank you.
That's brilliant, Ben. Thank you very much. And Ben will be staying around to answer your questions through the Q&A function. So next up is Mehmet Cem. Mehmet is a specialist in hip and groin injuries. He's recently completed his MSc in Advanced Neuromuscular Physiotherapy. He's the manager at Nuffield Health Taunton. He's also part of their injection service, and he's an advanced level physiotherapist team and works at the Sports Injury Clinic in Exeter as well. Mehmet, thank you.
Well, thank you very much. No problem at all. Although I am definitely feeling a bit stitched up being the only one talking about hips this evening.
The reason.
Because Paul knows that I'm an Arsenal fan and he stitched me up. But nonetheless, I'm going to try and talk about the interlink between hips and knees this evening. Paul's obviously given a bit of an insight as to what I do. Obviously, I work as a physio manager and have specialised in hips for a little while now. And I guess the reason why you guys are stuck listening to me talking about hips at a knee meeting is essentially because hips are divisively and arguably the most exciting joint. I'm pretty certain Shakira's never sung a song about knees, and where else are you going to be able to deal with groins and glutes and bums, except for when you deal with the hips. But joking aside, what I want to try and focus on within quite a short time that we've got to discuss everything is the interplay between hips and knees for those who have hip OA and knee OA, and really trying to go through a bit of a clinical picture for these patients in this short period of time together, so that all you participants that are watching have something that you can take back to in clinic, and something you can find useful. Because I think there's quite a lot of information we could go through for hours or in a day, and within 10 minutes, I want to just try and pick up some useful nuggets that you can use for these patients. So OA for the hip is one of the most common diagnoses and pathologies that we see in adults. So it's really important that we understand how these patients present, the location of the pain distribution, and really what does that mean for their presentation and how we assess them. Now, when our patients walk through the door, they're all really giving us a whole heap of information, and we need to be really mindful of that. As clinicians, expert clinicians, experienced clinicians, and even as juniors, we're going to be bringing up those hypotheses as to what we think is going on with this patient before they've even started talking to us. Those visual cues that we're going to gain from them about, how they're walking in, how they sit in, noises they're making when they're sitting down. All of that is giving us some, visual cues already, and then they're going to start talking to us, and that's what's really key, because they're going to start telling us where their symptoms are. Be under no illusions, we all have our own biases, me included, and I see a lot of hip patients, and it's easy for me to fall into that bias of thinking, well, someone's walking with groin pain, they fit the demographic of someone who's got OA, it may well be that, but I want to play devil's advocate today when we go through the presentation, so we can really get a clear understanding as to how variable these presentations can be with those who have hip pain and may well be, experiencing symptoms of knee OA at the same time. So we'll talk about knees a little bit today. I'm not completely a one-trick pony. Let's talk about the clinical picture. So those patients who present with signs of OA in the knee may well have similar symptoms in the hip. They may well have had a hip replacement before, or they may well have, issues in two areas of the body, in the hip and the knee. But why does that matter? What is the clinical relevance for that? And one of the things I want to touch on is really just how those with hip arthritis can present. Yes, we know that a lot of them are going to present with groin pain and buttock pain, but that's not the only way that they're going to present. And actually, when you start looking at the research, and it's not just anecdotal, evidence that we notice in clinic with our patients, the research backs up that actually quite a large percentage of patients report pain quite far distally, even as far as the shin. And that's quite important for us as clinicians when we're assessing these patients, because we have to have a real clear understanding as to what the pathology is. What is it that we're treating? Because we need to know that in order to give our patients the best level of care. And we'll be selling them short, especially those ones who come in even with X-ray, images or MRI images and have a set diagnosis. We'll be selling them short if we stick to that. And like I said, I'm going to play devil's advocate just to kind of be a bit critical with these kind of patients. So we can, when you look at the research, there or thereabouts, 40% or so with hip OA will report some anterior knee pain and some shin pain. And that may be just referral along the nerve branch. But what's really important from that is getting an understanding and being aware that when that referral path doesn't necessarily fit what you're expecting, we don't always necessarily need to jump to the spine, because I think that's what we always do. We think, okay, well, it doesn't fit the picture that I'm normally used to seeing. That hip patient doesn't necessarily have all of the pain around the groin and the hip, but they're getting more kind of like knee pain and shin pain, and all of a sudden we start trying to kind of get the lower back involved. But looking at the slide from before and from what we're discussing, sometimes that's not necessarily the case that we need to worry about. Actually, it may still well be the hip, and that's when we need to really start merging the patient's symptoms and clinically how they're presenting. Now, let's fast forward a little bit. Let's say this patient is coming into your clinic and they may well have already had some treatment, or you've already been treating them for a little period of time. And then the question about imaging comes to light. Now, we can't just rely on imaging. That's a point I need to make clear from the offset. Now, I'm not saying we need to swing so far along the paradigm that we never refer patients to imaging. That's not what I'm saying. But we just can't rely on it on its own. Now, the reason for that, when you look at young athletes, for instance, who have no hip symptoms at all, who have no symptoms, we've already seen in the last couple of years from the research quite a high prevalence of labral tears. So that's fine. But then let's think about that a different demographic, maybe the demographic where we would, expect to see OA of both either the hip or the knee. And actually, when you start looking at those asymptomatic hips and knees, those findings are still coincidentally still coming up with imaging. So for instance, chondral defects, labral cysts, paralabral cysts, bony edema, although it's not necessarily as high as labral tears in those who are more athletic, those OA features are still there and they're still prevalent. And I think when there is any prevalence at all, we need to be mindful of that. And we need to incorporate that knowledge into the whole patient's management program, because I think that's quite important. Again, coming back for us to get a clear understanding as to what we are actually dealing with. And so then when you're treating these patients, you can really clinically reason what it is that you're treating, because as we know, patients love a diagnosis and they want to know that you're confident with what you're doing. So you essentially have that evidence to back it up. So let's fast forward a little bit more, because I think, like Stuart said already, we've got Paul's sorted us out with speed dating timeframes tonight, so I need to whittle through it all. Let's say we have a patient who has knee OA. We've diagnosed it. We've done all the tests, we've done injections, we've done scans and X-rays, whatever. That diagnosis is there. So we know that quads are going to be weaker. Now, that quads weakness may well even precede the diagnosis or the pathological process. But what about the hip strength? So that's the key thing here, you know. Like I said, hip is king. You know, we need to implement so many different exercise strategies to address weaknesses elsewhere. But it's all well and good us giving these exercises, but what is the reasoning behind it? So there's a moderate amount of evidence for hip abductor weakness in distal joint pathologies like knee OA. But that's not just with knee OA, it's the same with adductor-related groin pain, FAI, hip OA. And it's not surprising when you think about how much function these muscles have in maintaining femoral pelvic alignment, femoral head stability, you know, just a couple of quite significant functional, you know, tasks that they have to do. It's no wonder that there's some evidence to demonstrate some weakness. Now, that's really important to know, because if we're going to be creating an exercise program or a rehab program, the question that we need to ask is, well, what's the optimum dose? What's the optimum type of exercise and rehab that we're going to give these patients? Well, it's hard to know, because the evidence isn't there telling us X, Y, and Z is the best thing to do prescriptively. And that's not just with knee OA. Like we know, that's with a multitude of different pathologies. But what we do need to have an understanding is the impairments associated with these issues, so that we can have a bit more of a targeted approach. Now, looking at that slide, I'm not expecting you guys to go to clinic tomorrow and look at all of your OA knee patients and say to them, we're going to try and improve that 6% deficit of hip extensor strength, because in reality, it doesn't really matter that much. But when you're starting to look at hip abduction strength, isometric, isokinetic, that's when the research is starting to show us more of a consistent nature that there is a strength deficit there. And that's really important to know, because it all comes back down to the clinical reasoning. The clinical reason as to what we think is going on, the clinical reasoning as to why we're sending patients for imaging or injections. But then also, if we're going to be giving exercises, we're still prescribing that. And that is a really important thing that we need to remember with our patients. We can't just give exercises in the hope that they'll get better because we know that squats or, you know, bridges are good for glutes or good for this or good for that. We need to have an understanding as to why we're giving it. And hopefully this very quick whistle-stop tour will just give you a bit of an insight as to where those strength deficits are as well. Now, I could probably talk about this forever, and you're all here to talk about knees, so I've probably lost half of you already. But if any of you have got any questions, my contact details are up in the top right corner there. So my Instagram, my Twitter is there. Ask any questions in the question box, as many as you may have. Obviously, Ben's given out his mobile number. I don't know if I'll take any calls, to be honest, but feel free to give me a shout if you've got any questions. I'll be happy to discuss this further. And thank you, Paul, and Össur as well for a great event.
Mehmet, thank you very much. I'll make sure I put your number on to all 750 applicants. As an Arsenal fan, that's the least you deserve. Have we got any questions, Giles, or can we?
None currently.
No, Mehmet, if you hang on just a little while and then you can answer through the Q&A function. Thank you very, very much.
Yep, no worries.
At least 5 times a year, we see in the NHS or everywhere, we see people who've had knee replacements whose symptoms don't improve, and you x-ray their hips and the answer is quite clearly there. Giles, are we okay? The camera's still on it? Okay. Get the patient, Charlie, come in. So I'm joined by Charlie, everyone, and also Andy Goodall, my good friend.
Hey, everyone.
Andy's a clinical manager at Pure Sports Medicine, he's an ACL specialist, and we've done a bit of work together on his Instagram and on my Instagram as well. We're going to run through a quick knee exam. Just 1 second. And it's going to be a basic level exam, and run through the things that all of us should basically be able to do. This is Charlie. Hi, Charlie.
Hi.
How old are you?
19.
19. What's your sport, Charlie?
Rugby.
Rugby, okay. And can you just tell everyone how you injured your knee?
Just grab that, Charlie.
Yeah, well, I was playing rugby and I got a contact injury outside my knee, and I tore my ACL. and my meniscus and my knee.
So the contact injury.
Yeah, through the side.
And someone came from the side.
Yes, yeah.
Did you try and get up?
Yeah, try to. Yeah.
Did you play on?
No.
Did you try and play on?
No.
Okay, smart move. So what I want to, and I always start off every ACL talk talking about causes of blood in the knee, and you're not to forget this. If someone has an injury and the knee swells up, it's caused by one of the following things. ACL, 65% of adolescents who have a traumatic hemarthrosis, it's ligament. A big meniscal tear, a fracture, a patellofemoral dislocation, and if for any reason your patient's on blood thinners, more the elderly population, and don't forget about that. So normally on my exam, Andy, chip in whenever you like, I get the patient standing up, so stand up for me.
So once he stands up, Paul, what are you immediately looking for?
So if we just flick to Stuart's camera, so I'm looking at alignment. Alignment is key in all the knee surgery. And the first thing you'll see there is he has got the most flat feet ever. Put your toes together, turn around. Okay, and just go onto your toes and down. And then if we stick on Stuart's, if you go down, just walk down the room for me. Okay, and I want you to jog back. Okay, so I've already seen him when he's a forefront runner. So he's always loading the front of his feet. And if we go back to the main camera, if you face the camera over there and just squat down for me fully. And up. And just come back a little bit. Okay, and just jump and into a squat for me. And you can see he's protecting his left leg. Okay, so now if you just have a lie down on the bed, and if you can, yeah, in fact, if you just have a seat and just swing your legs round, that's it. Just have a seat on the bed and just shuffle back. And now, when I'm checking patellofemoral tracking, Andy, I do it I sit next to the patient, put my hand on the patella, straight up. This one. Yeah, perfect. And down. And up.
And what specifically are you looking for there, Paul?
Looking for the J tracking of the patella, and also at what degrees does it engage. People have a high patella, they don't often engage till much later. Straighten out for me.
Do you find there's a difficulty on an acutely injured knee, if there's swelling and whatnot? Will that change maybe what you see?
Correct, and I might not do this test because I'll be looking for other things.
Okay.
Okay, have a lie down. Okay, let me know if anything hurts. So the other key thing here is when you're doing the ACL test in particular, get the patient flatter. Okay, so you're going to struggle to do a Lachman or an anterior draw or a pivot when the patient is sat up at 80 or 90 degrees. Now, the key also alignment, so we're checking alignment, is whether the patient has hyperextension. So you can see a bit of hyperextension on this leg. Always compare to the good knee, particularly ligaments, okay, because that's the good knee. So lift up straight, checking full extension, bend down, and my fingers on the joint line. Just checking to see if I can feel anything, any crunching, any crepitus, any meniscal tears that are large and I can feel them clicking. He's got a little click on the outside of his knee.
When you got him to raise the leg up straight,
yeah.
In particular, what was you looking for specifically? Was that a quads activation? Can you keep it? Yeah?
So for those who see the patients very early, i.e. pitch side or the Monday morning clinic, make sure they've got a straight leg raise. If the patient's got a straight leg raise, you know the patella's not fractured badly. You know the quads tendon's intact, you know the patella tendon's intact. Okay, so, and look for full extension. Full extension and good alignment are key to all of knee assessment. So if you come in on Stuart's camera now, we're just going to do a sweep test for an effusion. So Stuart, just focus on here for me. Okay, so we sweep up and you can see the effusion. So I'll do that again. Sweep up. Can you get that? Perfect.
If you're going to grade that effusion that's sitting there, what would you grade that as?
Well, I think any effusion we can find as clinicians is going to be a big effusion.
Yep.
Yeah, so I'd say it's moderate at least. It's not massive.
Yeah.
Okay, but he's got a good going. I'll do it one more time. Okay, I don't find the tap test or anything useful. A sweep test is very quick and easy. Okay, lift your leg up straight and bend. Okay, so when you're doing joint line tenderness, let's just see if it does come on there. People often find that the meniscus is here. It's not here when we're looking for meniscus. We're looking right at the back here, the common posterior horn medial meniscus. Almost where this groove is where we're feeling. Any tenderness there?
A little bit, yeah.
A little bit tender, and it could be where you're pressing, so you get the other leg up and do the same. Feel the same?
Yeah.
So it's the same pain? Okay, because that's important. And if it was positive, you go in and just do a simple McMurray. So all it takes is up and down. My fingers are on the joint line and I'm rotating. My thumb is on the lateral joint line. Okay? And in effect, what you're doing with the McMurrays anyway, you've already done it is with a loaded squat. That should be enough. Okay? And so drop it out to the medial side. You're checking a bit of hip there as well. You pick up your hip pathologies and then onto the lateral side as well. Okay? And then, so that's meniscus. And then we're going to do the ligaments. So I don't tend to do the anterior draw, very rarely at all.
Why would that not be the case for you?
I'm going to show you. So if we lift this one up as well. So typically, you're going to peg the feet back. So if I do that one, I don't know whether from the side it looks positive.
Yeah, maybe come so you can see the side angle. I was going to maybe come in so you can zoom, just so you can see the side angle.
Come here, Stuart. And just from the side. Okay, so I don't know whether you can see from the side.
Yeah, so what I find interesting here, I think will be corroborated by the next few tests. So if everybody looks at that and sees there's very little difference, the next test will kind of reveal why we don't favour that. So
a Ligament. So we'll go back to the front camera first. Get the patient's head flat. That's very important, and relax. And to check they're relaxed, just lifting the heel up, let the hamstrings relax.
It's nice and
okay.
floppy.
Any issues? Give me a shout. Okay, and I obviously wear trousers. I can do this test. It's got a big leg. You don't need to, but from the side you can see a grossly positive Ligament test. Okay, so if we go to Stuart's camera now, Stuart, if you come in, side view if you can. Okay, again, relax. Okay.
In your mind, Paul, what potentially gives us the false negative on the anterior draw there? Why do we see a sort of positive Ligament and maybe a negative anterior draw?
I think the patients aren't relaxed.
Yeah, so I agree.
Hamstrings aren't relaxed.
Yeah.
And you always compare. And if you do this on this leg, so you can see there is a little jog, but it's a different leg. Okay. And then I do a pivot. Now, if I get time, I'll go to my side. A pivot is if you lift the leg up just like that, you can see yourselves from the side that the tibia is anteriorly subluxed.
Yep.
Okay, and when you put the knee to valgus internally rotate, the tibia reduces. That's the pivot shift, and they don't like it normally.
Yeah.
We did it quite slowly, but when the patient's relaxed, you can do a pivot shift like that.
Yep. And this is a reliable test, isn't it? And certainly more potentially reliable if they're anaesthetised. But I think people move away from this test because they feel they can't do it when they're, you just need to get the patient relaxed. Essentially, that's the main thing.
If you've got the Ligament, you don't need to do it.
Yeah.
But now I'm here, I'm going to do the medial. The full extension. That looks like a lot of movement. We go to Stuart's camera, please. Okay, so remember he had an MCL injury as well.
Would you do that at 30 degrees as well?
I did, yep. So he's still got a jog on this side as well. Okay, and this side, 30 degrees. So he's definitely got some MCL opening up here. Okay, but it's subtle because his other one moves as well. So I'm also, when I'm doing that, I'm obviously testing the lateral side as well.
Can I show a little version so if you just slightly shuffle to the edge, one that I quite like, sometimes you get a big rugby player, big leg, sometimes you can just drop the knee from the side, use the stability of the bed, you've got less that you need to hold, stabilize the lateral portion, and then from there you can get that gapping on the MCL, which is quite a nice way. If you've got a heavy leg, then you've got less support, you're pinning the knee and you can get that MCL open. So that's another quite nice one. What about Lely test?
Oh, you do a Lely test.
Okay,
now,
so
I don't like the Lely test for this reason.
So this is why this is interesting. So there's been a lot of debate about the Lely test recently. We've done a draw, false negative. We've done a Ligament, we've got a positive. Now, if you get a Lely test, which is the lever sign, you get the fist under the calf, and then we're pushing down on the thigh. And what we'd expect for a positive Lely is for this to raise. You get this lever action. What you can see is we know that we have a positive Ligament, so we know we have an ACL rupture, and we have a negative Lely test.
Correct. So that's why we don't do the Lely test, and the Lely is not gradable, whether Lateral, grade 1, grade 2, grade 3, or an endpoint. Okay, one last test I'm going to do, just in the interest of time, is the posterior lateral corner. So the posterior lateral corner is made up of the LCL, the popliteus, and the popliteal fibular ligament, and we use a dial test. We use it more for PCL. You must do it when you're doing a PCL. So we'll just quickly do a PCL. Both knees at 90 degrees, both together, and from the side, you are looking for a sag. So you can see, you look at the tibial tubercles, you might use a pen or something to align them, and you'll see a sag, and you'll test it at 30 and 90 degrees for a posterior draw. And again, look at the ACL. It feels much more tighter than the anterior, than the Ligament test. And then for the dial test, it's important that you get someone else to hold the knee. So doing a dial test at 30 degrees, and if you come and hold the knee,
Let's just hold them together.
yeah, and then do the dial test. Because otherwise, if you don't, if the knees are gapping, you can't control what's happening, okay? So always get someone to hold the knees. You can do it supine or you can do it prone.
Yeah.
And prone's easier because you might do 30 and then at 90. 30 and 90 tells you the PCL and the posterior lateral corner are done, and at 30 it might be just the posterior lateral corner. But this is really important. So if we go to the front camera, so the ACL is often in a contact injury associated with other damage. Because the classical history for an ACL is a non-contact pivot on a pitch, and they can't continue, okay? With a contact injury, the medial collateral ligament and the posterior lateral corner come into play. And if you don't attend to those, then there may be an earlier failure rate with the ACL.
For me, the dial test is one of them that you just have to, if you know you've got an injury that you're suspecting a potential ACL, it's a test we should be doing anyway. Let's rule out a very significant injury that we know can be a problem if not picked up early on. So it's a staple.
Okay, so do you want to go and load up Andy's talk for us? Do you have any questions, Giles, on clinical exam? Any coming in? So do you want to ask me anything else, Andy, while we're loading?
What would make you do, or why would you do that in supine, that dial test? I've always routinely done it in prone.
So to be truthful, I do it prone.
Okay.
Okay, and I'll do it prone if there's a PCL, because I can definitely get them up to 90. I can measure it at 30. But you can do it supine as well.
Okay.
And often we're used to doing it supine in the operating theatre as a double check. So we have to do that because we don't want to flip the patient again. If I'm about to do an operation, I want to check the posterior lateral corner again. I'll do it. You know, we need to do both.
Yeah. I think my only other point I would have raised was, would be if you're anterior drawing for ACL query PCL, make sure you observe the start position of when you begin the draw, because you can subtly think you've got an ACL when in fact you might have a PCL.
All right. Okay, Jay, thank you very much. So we're going to head with no questions, Charles.
There's just one question in terms of any ideas to test for ACL or provocation tests for virtual assessments. Do you have any thoughts on virtual?
So the ACL diagnosis is normally in the history. The patient will tell you they were unable to continue their activity. So what I would do on a virtual assessment is make sure they've got a good straight leg raise. Okay. Obviously on Charlie, you can see when he did a box jump, he was loading preferentially his good leg, but he will tell you the history is, the number of times the patient goes to me, oh, I had this injury on the weekend, and I say, you've torn your ACL, and they go, how do you know? And I go, you just told me, because the history is classic. But the reason we brought Charlie in is because of the other injuries. And when you've got a contact injury, you have to examine the patient. It's not good enough just to have an MRI scan.
Okay, thank you very much.
Anything else?
That's it.
So I'm going to go straight to Andy, because not everyone who tears their ACL needs an operation. Andy.
Okay, I think I'm on. Yep, great. What I wanted to, or what I was asked to talk about today was, does every patient that tears their ACL need surgery? And this is something I talk a lot about, in fact. So I put up a few aims. Hold on, there's just a text box on my screen. Why aren't we moving along? Hold on, sorry about that. So a few aims for my session. I just want to myth bust some of the reasons we traditionally have said to patients that have torn their ACL that they might need a reconstruction, and just our sort of current thought processes. I want to talk a little bit about the decision-making process which may be behind who does and doesn't get an ACL reconstruction, and then just highlight some criteria. I've only got a short piece of time, but highlight some criteria you can use in clinic that might help you determine whether who is a coper or a non-coper. So, why would we routinely reconstruct the ACL? And these are more sort of traditional ideas around why we might do so. So I think the first one that most people would talk about would be to get the knee back to normal as such. Now, what I mean normal is reducing pain, improving sort of daily function, ADLs, and potentially returning back to sport. Second being, or the traditional, is prevent osteoarthritis. And the third, I would argue, is to return to sport. So what we're going to talk about is some of the ideas behind this, and then also how we might look at this currently. So I've cherry picked an article here. It's a fairly famous article on ACLs. And this is to talk about the ACL reconstruction to get the knee back to normal. Now, as you can see, this is the traditional Frobel study. We've all seen this. If you've into ACLs, you've read this, and it has its flaws. But the main thing I've pulled out here is if you look at 12 and 24 months, and there's further studies around 5 years and further on, whether you have an early reconstruction, a delayed option to have a reconstruction, or whether you have rehabilitation alone, the KOOS, which is a score that shows pain, return back to ADLs, and sport and such, and many other key variables, actually, those three categories do relatively similar. So the question is, can we say that you need an ACL to get your knee back to normal? Maybe not. Now, the second one we spoke about was osteoarthritis. Now, if we are to say that the ACL reconstruction prevents knee osteoarthritis, perhaps that's not true. Now, we know that the surgery now can't prevent osteoarthritis. In fact, RA rates are pretty equal between ACLs and ACLR, and non-surgical management in some studies. And if you have an isolated ACL, whether you do or don't have surgery, the OA prevalence is relatively small, or is similar, sorry. Now, this is different if we're talking coexisting meniscal chondral marrow lesions. These definitely present with a higher rate of osteoarthritis. And I think the common acceptance now is that actually it's the injury, it's the damage to the bone, it's this marrow lesion, this assault to your knee that happens at the start, which is actually begins the process to osteoarthritis, rather than the traditional sense of purely instability being the cause of the progression to osteoarthritis. I'm going to go back, sorry about that. And as you can see, this is a study that was done on some pro athletes and via Beneprin, and showed that actually ACR or non-ACLR, and I believe it was 50 in each group, there was no difference between meniscectomy rates, radiographic OA, and functional outcomes at 20-year follow-up. And that's the key. That is a relatively long follow-up in ACLs, and it shows there's relatively small difference. So can we say that you do or don't need an ACL reconstruction to prevent OA? Maybe not. So how about to return to sport? And this is my final point. And at present, the return to sport rate is relatively similar at 2 years. There are some relatively damning stats, and I'll just pop these up as we talk, whether you have an ACL or don't have an ACL, and the reconstruction. And these stats aren't hugely positive. And if we look at those re-tear rates, and if we look at those that are still playing sport 5 years down the line, 20% still playing their pre-injury level of sport is relatively poor. And this is, we're talking for those that have had surgery or not had surgery. So again, can we say that the ACLR means you can return to sport, or if you don't have it, means you can't? Maybe not. Now, in practice, and I see lots of people that do have ACL reconstructions, so I'm certainly not against all ACL reconstructions. I just wanted to bring some of this to the fore. Who gets an ACL in practice currently? And like I say, lots of these factors, certainly the younger group, those that want to return to level 1 sports, skiing especially, high tubal slope perhaps more with those that are having a second reconstruction, hyperlaxity, and many others such as ACL plus. Now, when I say ACL plus, what I mean there is like what me and Paul were just talking about. ACL, medial meniscus, and an MCL would probably mean that that person has got an increased amount of instability, because we know the medial meniscus, we know the MCL help to stabilize the knee, especially to those valgus strains. Plus the ACL means if you're having these combined injuries, you're much more likely to do better with surgery than you would non-operative. That doesn't necessarily mean you have to have the surgery. We're just suggesting that you might do better with it. Non-COPA, I'll talk a little bit about what a COPA is in a second and why that's important. Most athletes, this is because, well, I believe this is because the sort of pattern for them returning to sport is relatively laid out if they have surgery at a well-known time frame. And as such, if they're having surgery and you can plan for it, teams and such can really make sure they know, given some when their player is going to return back to sport. Although there's some variability, you know, most will return back to sport in around 8 months. The other one is those that want it. So if you want your ACL reconstructed, and especially those in the Fro Bell study, those that have the psychological belief or those kind of psychological feelings that they need their ACL to be reconstructed to return back to what they want to do, those definitely do better if they do have an ACL reconstruction and are the most likely to convert from a sort of non-op management to a surgical management. Okay, so COPAs. Can we identify COPAs? And this is key. This picture in the back is one of the West Ham players, very famous study on him returning back to sport in a very short time frame without having ACL reconstruction. But can we identify those in practice? Now, what is a COPA? A COPA essentially is a patient who has an ACL deficient knee with good knee stability who's able to compensate. And I'd argue, if you look through the literature, there's no perfect way to identify these. And I think there's a number of strategies to do so. And what I am going to show is a batch of tests as such, or a batch of criteria, which help you to identify who may be best or who may be most likely to cope without an ACL reconstruction. Now, I've pinched these from the reference in the bottom right-hand corner, but they're essential, really. We're a quiet knee. So what do we mean by a quiet knee? You know, no swelling and good function in the knee. So we're looking for quads are active. We're looking for, you know, full range of motion. They should have had less than one instability episode. So they've had an instability episode. That's when they tore their ACL reconstruction. Preferably, they would have no more after that, but we'll allow them to have one maybe at the start, but hopefully with no further injury. Hop tests. Now, this is a battery that they use in the Delaware Oslo group. They use the single hop, the triple hop, the 6 meter timed hop, and the crossover hop. Now, you can have derivatives of those and each have their favorites, but a batch of hop tests should be included to try and help you understand whether this patient is performing well against their uninjured side. A measure of their function, so they use the COS ADLs, looking for greater than 80%. This is pretty well referenced in the literature and used by many. And then again, another sort of global rating score. This is a patient-reported measure, which they would tick a number of selections and they would be looking for a score that's relatively high. Now, what I want you to take from this is those that cope essentially are performing at very close to their previous level, or, you know, probably 70+% of their previous level with regards to their function, you know, at maybe 12 weeks post their injury. And the key here is that we give them a chance to achieve those variables. If we jump in, certainly those that are non-elites, if we jump in and we do surgery very early, perhaps we're not allowing those people that would cope to have the opportunity to cope. So I would argue we need to be giving them 3 months of non-surgical rehabilitation, if appropriate, as long as there's no reason to, you know, as long as they've not got a massive bucket handle tear that's locking their knee, for instance. You know, I would say give them a chance, test them appropriately. The one thing that isn't mentioned on here is strength. I would always add strength to that. I would be looking at a quad strength measure, which you might do via kinetics testing. You might do that by handheld dynamometry, but you'd be looking for a score versus the other side. And preferably you're comparing that to as close to their injury as possible. So add strength, use these markers. Have they passed those? Are they a COPA? If they're a non-coper, maybe they just need a bit more time. Maybe 3 months isn't enough. Give them a bit more time if appropriate. If they're getting close, perhaps they will manage non-op. Okay, finally, some take-home points. I realise that was whistle-stop, but some take-home. In practice, many still get reconstruction as a primary treatment offering. Maybe we should look at this on a case-by-case basis rather than a blanket treatment. We can't say that OA, future surgery, functional outcomes and return to sport rates are similar across the literature base. So we can't say everyone needs an ACL reconstruction. We should use criteria to help to understand who will do well non-surgically. There's plenty we still don't know, so I'm not claiming that's everything there, but there's plenty we still don't know. And again, like I said earlier on, let's not throw the baby out the bathwater just yet. ACLR is appropriate for many. We just need to try and pick the right ones. Cool.
Brilliant, Andy. Thank you very much. That's brilliant, Andy. Thank you very much. We're going to go straight on in the interest of time. Andy will be here to answer your questions on the Q&A function. If Glenn's ready, we're going to go to Glenn. Hi, Glenn. Glenn, as an introduction, originally worked in the fitness industry as a trainer. He qualified as a physio in 2005. He initially worked in Iceland before returning to the NHS and doing his MSc. His main passion is manual therapy, functional movement screening and injury prevention. And most of you will have been on courses or been mentored or trained by therapists, including Glenn. He's involved in the creation and development of strengthphysio.com, and he does a lot of online CPD. Today, he's going to be helping us talk about Compex and cryotherapy. Thanks, Glenn.
Thank you, Paul. I will just share a screen now. So thank you for that introduction, Paul. A pleasure to be here this afternoon talking on adjuncts in knee rehab, particularly Compex and Cryo. Nice intro from you there. What I will add to that is that I'm also 2 years post ACL reconstruction. So I will give a little warning that there might be a little bit of N=1 bias here because I have used the Compex and the cryotherapy extensively through my own rehab journey. The aims of the talk hopefully will highlight the benefits and uses of these adjuncts, illustrate some novel progressions and additions, highlight how their uses may change depending on the stage of the rehab that we're in or the level of the athlete that we're dealing with. So I think particularly if we're looking at ACL, there's some decent evidence to suggest that if we add in some muscle stim in the early stage, we will get a quicker return to quad strength, particularly in those kind of 4 to 12 week stage. So ideally, if we're seeing someone pre-op, which in best case scenario we will be, we can get them going with a muscle stim, and it should lead to greater improvements in their quad strength when we get them going actively post-op if they're using this straight after surgery. There is some papers out there to show exactly what settings we should use potentially, but I think the caveat really is the maximum tolerable setting that you can use in those days and weeks after surgery is what we should be aiming for, and getting them familiar with that previously is always a good idea. It's my knee here post-op using the Compex. And now I'm just going to show you a couple of videos how we would progress this. So I think we can establish that using Compex immediately post-op is beneficial, but I also will use it in various stages. So when we're transitioning from that early stage, we're starting to do some body weight circuits, or in this case with professional athletes, if we're trying to deload their external force on the run up to a major event. Sam, the future Patterson, professional MMA fighter, Brave, Combat Federation and CrossFace Gym. We're going to show you how we use the Compex when we're incorporating it into a training program. So we've got the pads set up. We're going to use an atrophy setting. We'll pick the quads, and then we're going to start the intensity going through the pads. So what we're looking for here is the maximum intensity that Sam's able to tolerate before his knee starts to extend. It's important that his leg isn't wedged on the floor, so he has to have that freedom of movement there, so when it does hit that intensity, he's able to move. You okay there, Sam?
Yes.
So we're just starting to get some movement there. So we'll take that around 66. So that would be what we classify as Sam's 1 rep max when we're using the Compex. Now we're not going to get him to train at that intensity, but what we're going to do is reduce that by half. So we're going to take him down to 50%, and then once we've got that intensity set, we can start to work through a variety of different exercises. So now we've set our intensity and we're going to use a small program. So you can use your imagination here. Any exercise that's going to load the lower limb. We're going to choose a lunge, so we're going to have the lead leg forwards. And then in between, when we're on the rest phase, we're going to use a bodyweight squat. So as the intensity starts to go through the leg, we'll ask Sam to do a few repetitions. Depending on the speed at which he does them will dictate the amount that he can do in each repetition range. So when you're ready, Sam. So we normally get around 3 or 4 reps, and then we'll get a relaxation phase. Now, so that we're not just standing around during the relaxation phase, we can incorporate some bodyweight squats. And then the standard atrophy setting will go around 75 times. That's excessive amount of time to do with this kind of training protocol. So we're normally half that. We may even go down to 25% of that range. And that would be our rehabilitation setting where we're incorporating a little bit of exercise, a little bit of movement, so they're not just sitting static on the couch. So you can see there are options there when we're using the Compex. So with our elite athletes, we use it when they're deloading. Sam is also a post-knee surgery client that we've rehabbed. So we use it with him in those stages when we're trying to increase recruitment without adding on additional load before we do a traditional strength and conditioning program. And you can see here as well, you can use it earlier when you're just trying to get those quads activations. We can use it on the posterior chain. So we can have isometric holds, or we can have a little bit more dynamic movement as well. So it's not just a question of sticking the Compex on the quads and laying there passively. We should be using them and incorporating them into movements, and having strategies and ways in which we do that, I think, is a nice way where we can transition the kit from the first stages into the mid stages and into bodyweight routines as well. So when we look at cryotherapy, we're switching on to cryo now. It doesn't have a ream of evidence backing up what we've traditionally been taught that it does. So in terms of anti-inflammatory effects and reducing swelling, there's only really minimal effects that I could find in the literature. But what it does seem to do pretty consistently is reduce pain. Yeah, so I think, again, it's a valid tool in that post-op stage. And coming back to this N=1 from my surgery experience, using a cryo compression cuff certainly did reduce pain levels for me significantly and enabled me to engage in my early rehab a lot more comfortably. And that tends to be backed up as well, that compressive cryotherapy seems to be optimal over just a standard ice pack. So again, here's my knee a couple of years ago with a fairly inexpensive bit of kit from Amazon. And if you want a little bit more upmarket kit, a bit better quality, then the Physio Lab stuff is a decent alternative for that as well, and portable also. But something that's really tickled my fancy over the last few years working with these pro athletes is whole body cryo. Yeah, so Charlie Leary there, he's one of the pro MMA fighters for Bellator MMA, said to me multiple times how whole body cryo is integral when he's coming up to a training camp. Same with Sam, who you saw in the video earlier. So I went along and had a go.
There you go.
Fairly intense, getting down to minus 150 degrees. So what's the sort of evidence there? So I had a look through the research, so we've got a nice review of the literature here. What's the effect on tissue temperature? So there's a lot of claims looking at reducing tissue temperature. No greater, in fact, not as great as an ice pack. If we're looking at physiological markers relating to reducing muscle damage, again, doesn't seem to have much of an input there. Looking at inflammatory biomarkers, bit mixed here. There is some evidence to suggest to the contrary, but on the whole, couldn't find anything consistently backing up those claims. But when we look at the hormonal effects, I found this really fascinating. So in terms of hormonal profiles, it does seem to consistently have an effect on reducing cortisol and increasing testosterone. So if you are working with athletes that are training excessively, and these guys that I mentioned before are doing on average 6 hours a day, 6 days a week, then anything that can have an effect on that and aid in recovery is useful as well. It does seem to have an effect on perceived recovery, although the caveat there is it doesn't seem to correlate in increased muscle power output. And quite different to ice baths and stuff, it does seem to reduce DOMS as well. So there are some very distinct benefits there. And what really interested me the most, I would say, is that it also, more recent evidence suggests that it seems to have a positive effect on heart rate variability. So with some of these guys that are training those kind of volumes, heart rate variability is a nice way of tracking if they've actually recovered before they do a next session, and it does seem to have an effect there. So in conclusion, I think there's a clear role for Compex and muscle stim and cryotherapy in those early stages of post-op recovery, but hopefully now you can consider muscle stim in the transitionary stages as well. And if you're dealing with elite athletes that are coming up to an event, then it could be a nice way of incorporating it there when you're offloading their strength and conditioning. Whole body cryo, if you haven't given it a try, give it a try. There are some benefits there, I think, that are quite novel to that, but you obviously have to pick and choose your clients accordingly. So pro sportsmen, elite athletes, and ultra marathon runners, crossfitters, the kind of guys that are overtraining potentially might benefit from that as well. So just like to thank you, a bit of a whistle stop tour there. If you are interested in the Compex have kindly offered a discount for all the attendees today, so just send me an email on that email address and I can link you with a very generous discount code there.
Thank you, Glenn. Just a quick question. When using neuromuscular stimulation, when the patient's static versus dynamic, can you explain the differences in outcome and your findings with that?
So the outcome for me really is anything that we can use functionally is always a benefit. Yeah, so I think the gap there really is how do you incorporate, when you're giving someone a maximal test, so when I'm getting them statically, I'll get them to have a maximum tolerable load. But that's not feasible to do a routine with, really. It tires them too much. The soreness the next day is considerable. So the difference is in the intensity that we set. So the method that I showed there, by setting a 1 rep max, and that's unique to them, and then taking a percentage of that is a good way of changing them from, you know, static to dynamic. And I think also when you're looking at someone post-op in that first week, they're limited in what they're going to be doing anyway. So getting the Compex on in that stage is really beneficial because it actually makes you feel like you're doing something active anyway. And certainly in my case, it had a benefit in reducing pain. I felt like my leg was reacting and waking up a little bit quicker. But as I said at the start, there is an N=1 bias there, you know.
Okay, thanks for that.
Glenn, brilliant. Thank you very much. And Glenn will hang around to answer any questions on the Q&A function, hopefully. Thanks, Glenn. Really good. Next up is Benoy Matthew. Benoy, hi. Benoy is a highly specialist physio and an APP. He's a specialist in overuse lower limb injuries and running injuries. He's also a master trainer in shockwave therapy. We've lost him a little bit. He's a trained MSK sonographer. And I think at least 2,500 people have been trained by him in the courses he runs over the last 8 years. He works in private practice in central London and he uses evidence-based practice. Benoy, thank you.
Thanks, Paul, for the kind invitation, and hope you guys can see my screen. Is that all good?
We're not sharing screen yet, so if you could share screen.
Yeah, just a second. Share screen.
Perfect. And just slideshow.
Yeah. Perfect. Yeah. Just a second. Okay, so thanks, Paul, and for the kind invitation. So my topic, which I'll be going through, is PFR in knee rehab. Just brief overview of what I'll be covering through. So as somebody who's working in lower limb, you'll see that cord deficit is a major problem. So it still can persist for years after multiple surgery. And also, you know, it's sort of there's been a rise in popularity in the last 5 years. And we'll be briefly talking about the safety, and it's definitely not for everyone. So although it's very safe, there are a few indications to go through. And it's something which I use pretty much every week. I had multiple knee surgery myself. The first time I used this was in 2009. 9 after my second surgery and my third and the fourth. So you can imagine when you have 4 major surgery, your quads never become normal again. So you still have persistent quads despite all the strengthening. For me, I think the BFR keeps that ticking on and hopefully prevent secondary OA, hopefully in the future. So I find that it's really beneficial, and I've been using with patients for the last 5 or 6 years with all the different devices. So now quad deficits is a huge problem. And as we know that, especially after an ACL surgery, about 20% of them have persistent quad weakness even after 1 or 2 years. And there are 2 key reasons. It is just not because of surgery or disease atrophy. There are 2 key distinct mechanisms, which I'll go through. And getting that deficits covered is extremely important, because we know one of the strongest predictors for knee OA is significant quad weakness. So it's really important that we address those early before it becomes a long-term issue. And so what are the 2 key reasons based on the literature where we feel the quad weakness happen? One is a central phenomena called arthrogenic muscle inhibition. So it tends to happen bilaterally. This is quite fascinating. Although you might have ACL surgery on the right knee, your left knee also gets weaker with your quads. So it's really important to bear in mind when you're rehabbing patient, or if you're doing muscle testing, or you're checking your handle dynamometer, that the opposite side is also weaker. So it tells it's more centrally driven. That can lead to significant weakness, and that might not respond to traditional rehab because of pain and ongoing issues. So the arthrogenic muscle inhibition is quite a fascinating concept, which mainly happens mainly after knee surgery, such as ACL. Less common with meniscal, but ACL definitely there's strong evidence there. And the second factor is the satellite cell. So satellite cell is something like your stem cells of your muscles, very important for getting your hypertrophy and strength gains. And when you have ACL injury, both conservatively or surgical, the satellite cells decreases. And that is really a bummer, because when you start strengthening and you're not getting the same output, I hear this from patients all the time, they're putting the effort, but the quads are not really improving the strength. And that could be explained by the low satellite cell abundance, which happens after a major knee injury. Now, historically, if you look at strength training, we have issues with this, because if you want to get a proper strength, you're talking about 60 to 70% or 80% and more. And that could be problematic for people after surgery. So if you're having a major surgery 2-3 times, or even after a simple ACL, they can't be lifting those weights in the initial phases, and they're limited by pain, the post-op restriction. The surgeons might not be too happy by going for ridiculous weight in that initial stage. So I think this is where BFR comes in. So we can get the same benefits with 70% 1 rep max with just 30% with BFR. So what is BFR? Pretty simplistic definition. You just reduce the blood flow. We don't stop it totally, and then you make them to do exercise with 20 to 30% 1 rep max. So it's a fairly simple concept. And for safety, we generally keep it within 10 to 15 minutes with the clinical population. For a general fit person, you could go all the way to 20 to 30 minutes. With my patients, I start with 10 minutes. I rarely go, or I never go beyond 15 minutes, which is more than adequate. It started from Japan. So key point here is it will not work without exercise. So you can't just put the cuff and watch telly and Netflix, and you're not going to get the strength gain. So you still have to do the exercises. It's a bit more intense, so it's not going to give the benefit unless you work out. But the advantage is it's less load and it's much quicker. So it starts from Japan in 1966 from Dr. Sato. There's plenty of review there. It started from the bodybuilding world, went to like CrossFit and other areas, and eventually come back to rehab in the last 15 or 20 years. So there's plenty of evidence proving that. And one key question which patients and everybody asks is, how does it work? So we know that it works with multiple mechanisms. The number one is the anaerobic environment causes a big spike in your growth factor. So it increases by around 200 to 300%. There is increase in your satellite cell, which I mentioned previously. And also there is a increase in type 2 fiber recruitment, which only happens with heavy load. So basically you're tricking your brain and your muscle to get the same adaptation what you will have with heavy loads with low loads. So your type 2 generally starts when you lift heavy load. So you're getting the same benefits with less load. Now, an important point is, should I stop lifting my weights at the gym? Definitely no. If you can lift, if you are somebody healthy with no knee pain or joint pain, and you don't have any issues, the best is traditional weight training. So adding BFR makes no difference at all if you can lift heavy. So if you're sort of doing your normal gym work and you don't have pain or pathology, there is absolutely no role for BFR based on current evidence. So it's basically more like a transitory step, more like towards your early stage when you can't do that. So it doesn't replace traditional strength training. So that's the key point. One of the interesting effects of BFR, which is quite fascinating, is pain relief. So this has been picked up in the last 3 to 5 years. So think of your patients like your runners with patellofemoral pain, or a knee OA patients who is just getting back into triathlon, or who are struggling with knee pain and they can't do a traditional weight training. There, I think the BFR could really be a game changer, because that can give you pain relief. And I've got a few articles which show that. Safety, really important when you're dealing. A lot of surgeons ask me about the safety elements. So just to mention, it's been used even in intensive care with heart failure patients. So this study has been done in intensive care in people who are on ventilator support, who are on supports to increase their heart rate and things like that. So medically unstable patients. And even in those patients, there has been no adverse effects. Obviously, you need a thorough screening tool. There's contraindications. We don't have time to go through that. But if there's only one article, if you get time to read on that, on the screening, I would recommend this article published in JOSPT in 2018, which goes through the screening process. When we started on the BFR journey about 6-7 years ago, we used to start with a normal set pressure. That's excellent for most people. But now we're getting new devices in the market, from the Delphi to the MADUP to the Airbands, where you can really personalize it to based on your on the individual, and that's will become more popular. So I think moving forward as a therapist in a clinical population, I would highly recommend to go more towards personalized bands rather than going for set pressures. So when we look into the evidence here, so this is an interesting study, looked at women with knee OA after the age of 60. So both improved. The now interesting thing was patients who did BFR had less pain. So it's a win-win situation. So if you tell a patient you're going to get stronger with less pain, I'm sure most people will choose that option than lifting heavy. So for people who are struggling with heavier loads and want to get the same gains, this might be an option. So similar with the younger population, this is mainly with runners with patellofemoral pain. So we do get a subset of patients with patellofemoral pain who don't tolerate squatting. So those sort of patients can benefit from your traditional, rather than traditional, they could go into your BFR route as well. So plenty of options there to build upon. So in conclusion, it remains an effective strategy. It's evidence-based. As a clinician, I would recommend to screen them, possibly get trained. There are a lot of companies which provide that, and it's definitely something you don't want to miss if you're dealing with lots of knees and hips, because it's, in my opinion, it's definitely a game changer, and it's here to stay. And the organizers from Airbands have kindly given the discount code for all the participants. The code is function to fitness. So if you're interested in Airbands, you got the details. So that's from me. Thanks, Paul.
Benoy, thank you very much. Benoy, look, we're going to move on, but if you have any questions, non-urgent ones yet, but will you hang around and just answer them on the Q&A function for us?
Yeah, definitely. Yeah, thanks.
Brilliant. Thank you, Benoy. I really appreciate it. Next up, we have Anne-Marie Winter. Anne-Marie is getting ready, I think. So Anne-Marie is going to talk about the fat pad, the bane of all of our lives, I think, for all patients who manage knees as a surgeon, as a physio, and she's going to teach us, I hope, or share some knowledge on how to do it. Anne-Marie's a local physiotherapist here at Weybridge and Walton Physiotherapists. Again, like so many of our faculty, she's had ACL or knee surgery herself, so she can speak from personal experience. And I don't believe there's anyone who rehabbed any quicker than she did. So let's see how she did it. Anne-Marie, thanks.
Hi, can everyone hear me?
Yep.
Okay, thank you, Paul, again for inviting me for yet another knee symposium. And thank you, Össur, for sponsoring this event again. So let's get cracking. Before we start, I just want to tell you all, I'm a clinician, I'm not a researcher, but I would love to share with you some clinical nuggets from my experience in knees, and fat pads are something that I see on a daily basis. So hopefully we could all learn something. All right, so what is a fat pad? As the word says, it's masses of adipose tissue that is scattered all over your body to perform some mechanical advantages for the musculoskeletal system. Now, for this purpose of today, we're just going to cover the infrapatellar fat pad, but there are two others in the knee that we can touch on. So the Hoffa's fat pad, some important keynotes is it's intracapsular, it's extrasynovial, it's richly vascularized and innervated. So along with the medial retinaculum, this is the most painful structure in your knee. and it's got a high proportion of substance P fibers. So if you just look at that bolded letters there, it all spells out a very irritable, sensitive structure. Now, fat pads have, especially the infrapatellar fat pad, has a biomechanical function in stabilizing the patella in the extremities of ranges. So we're talking about less than 20, more than 100 degrees. Now, there's a study that showed this, which is really fascinating, and it links in with what your patients would complain about. They would come in and say that their symptoms are reproduced when they try to extend their knee or when they try to do deep knee flexion motions. And this links in with what they found, that the smallest volume in the anterior knee compartment is at these ranges. And they would usually say they're most comfortable in the middle ranges, around 50, 60 degrees. Now, another thing to note is we all have an infrapatellar fat pad. That's been proven, and usually it's constant in its shape. So if someone has a larger or funny looking fat pad, it's not just the way they were born, it's abnormal. So fat pad pathological presentations, in my opinion, we can put them into 3 categories. The first one would be post-traumatic, and this would include post-surgery as well. So think of keyhole surgery, but they enter through the fat pads. Think of your hockey player, your child that comes with a direct blow from the knee, or someone that fell on their knees, or even your manual laborers or your builders who spend a lot of time on their knees with that repetitive micro trauma onto the fat pad. Second category would be your classic Hoffa's infrapatellar fat pad impingement. Okay, so a lot of the time these people have some underlying biomechanical dysfunctions as well. So you need to look further up or down the chain, as mentioned by my colleagues earlier. So think of femoral internal rotation, think of your hip weaknesses, look at ankles. I personally find that there's often a quads inflexibility issue with these people. So they're really tight in their quads, or on the other end of the spectrum, they'll be quite weak in their quads. There's often also a patellar mobility issue with these patients too. Now, the weird and wonderful group is all the stuff that makes you go, what do I do here? Lipoma aberrations is one of those. You see the name, you think, what's wrong with this patient? But basically, it's a fat pad issue. It is benign villus proliferation, as they say, of the synovium. So it's basically a reactive response of chronic synovial irritation, and it pops up into the suprapatellar pouch. So it looks like a really fatty chunk in the suprapatellar lateral region of the knee, but we'll treat it just like any other fat pad. So as long as you have identified your problems, you can treat any weird and wonderful name. Quads fat pad impingement is just another one that you won't see that often, but just keep an eye out for that one. So how would I assess a fat pad? I think it's actually pretty straightforward and really quick to do. I'll always get the patients to stand comfortably barefoot in front of me, and I'll just look and let their body tell me what's going on. Look at the fat pad sizes, look at the shape, look at the patellar positions, look at quads bulk. How is that relative to glutes or calves or hamstrings? Is there an unbalanced amount of quads compared to really like no glute development or oversized calves but no quads? Just look at what the body tells you. Femoral rotation you can often see in these positions as well. Now, functional tests that I run through with these patients would be your classic double leg squat without prompting them how to squat. I want to see what's their natural inclination to squat. How do they choose to move? Single leg squats, lunges are great to identify fat pad issues, because if you think back on slide 1 or 2, where we talked about the extreme ranges, and the lunge takes you through those ranges. So you really have the chance to pressurize the volume of that compartment in the anterior knee. Deep squat is a good one, because it not only differentiates between your meniscal issues or other internal structures, but it can also reproduce your symptoms, and you can identify altered movement patterns here too. So fat pad size, I like to draw on my patients with their permission, but it helps them realize what I'm talking about. So this patient here, I took a permanent marker and I drew the outlines of his fat pad, so we can actually see that in relation to his patella and the tibial tuberosity and everything else, his left fat pad was definitely larger than the right. And this lady on that picture, you can see she has an old scar across her right knee horizontally, and that's from surgery 20 odd years ago. But her right infrapatellar fat pad is enlarged, and that's the classic post-surgery, post-trauma one. So how would I assess it furthermore? Hoffa's test is a good one. to identify pain, but also I use it to feel for unusual sensations in that anterior knee compartment. I get a lot of information from just using my thumbs and my fingers and just feeling and listening to what the patient says. Mobility of patella, I love because I think this gives me the most amount of information. So we're talking about medial lateral tipping and inferior superior tipping, as well as gliding in a medial lateral or cephalocaudal direction. So if we look at the first video here, this person's got great medial lateral gliding, but her superior inferior tipping is non-existent. Super tight, no movement. And if we look at the second video, really good at that size. This is a normal knee. Great directional tipping. So that's that. So quads I'll assess as well. And here we look at tone, strength, and flexibility. Tone, in other words, touch, feel. What does that quad tell you? Strength, we must be objective. In the current day and age, we cannot be talking about Oxford strength tests anymore. We have to use something that's measurable, that's accurate and reliable. So if you don't have resources to an EMG or handheld dynamometer, then be creative and think of repeatable movements such as step-ups or a single leg squat to fatigue or a weighted squat with X amount of weight, something that you can objectively measure and document and use to check whether you have actually progressed with this patient. Now, treatment approaches. This is a busy slide, so forgive me for that, but I thought I'll try and just jam it all in, and you can take a screenshot and just read up about it a little bit afterwards. But once you have identified your problems, now I really always write down a problem list for each patient. What are we dealing with? In my opinion, with fat pads, it's one of 5 things. It's either an enlarged fat pad, number 1, or it's reduced patella medial lateral gliding, number 2. It could be scarred or fibrotic tissue in the fat pad, number 3, or it could be reduced superior inferior tipping of the patella, number 4. And lastly, if all else fails, it's probably biomechanics or quad strength issue. So I've highlighted the take-home messages here. If it's an enlarged fat pad, you will manually release it. You'll ice it, you'll advise them to ice it so it can shrink. Diamond tape technique works really well to offload the patella, and this is the type of patient that works well with ultrasound or injection therapy. If it's a medial lateral gliding issue, that for me spells out quads. So quads tone, quads flexibility, foam roll, release the quads, get them to mobilize their own patella. And when you want to do strengthening work, remember what's the problem is a tight quad. So when we do strength work here, we'll do eccentric quadriceps rather than concentric, so isometric, just not to add any more tone to it. If there's a scarred or fibrotic tissue in the fat pad, you need to do deep frictions to release it. The patients hate it and they feel, and I know what it feels like. It feels like someone digs a knife into your knee, but within 1 session, you feel a relief and you feel greater range of motion kicking in. So these people I would encourage to kneel. If it's a parent, kneel to bath your children, kneel to sort out your cupboards, because that pressure and that desensitization on the scarred fat pad is really helpful. And with rehab, I'll do exercises that encourage the inferior gliding of the patella into that scarred tissue to stimulate that softening up furthermore. Now, the superior inferior tipping, you can just run through there, but what I find useful is rock tape, the Y strip, that's quite useful for that, just to help with that mechanical advantage. But number 5, I think, is the most difficult one, because this is the patient that anatomically I can't do anything for. Manually, I won't do much for them, but I need to educate them that we're in it for the long run. We need to work on movement patterns. We need to work on strength and biomechanics, and that's going to take time. And once they buy into that, you can be successful in treating them effectively. So I think in a nutshell, I've done it. But any questions, please shout.
Thank you very much. Really good. Anne-Marie, we're going to move on, but please stay around on the Q&A function if anyone's got any burning questions. Okay, so next we're going to go to a live demo of, we're going to switch the cameras, Giles. Live demo of end-stage rehab. We have Tom Williams here from Activate Rehab. He's an ex-GB water skier. He's now the physio for water skiers, the GB water ski team and wakeboarding, and he is an elite level physiotherapist. He is going to run through end-stage rehab in 15 minutes. Andy Goodall, probably one of the few people who have not had a knee operation yet, so we're going to try and change that. by putting him through the end stage ACL rehab. Tom has got slides running through the whole phases of ACL rehab, and if you DM him at active8, number 8, rehab, or Tom Williams Ski Physio, he will send them to you. Gents.
Right. Thank you, Paul. Great to be here. Right, so running through the stages of ACL, my talk today is on the end stage rehab, but to get there, you need to go through the acute phases, getting extension first, swelling under control, and activating the quads via terminal knee extension. That's your priority at the beginning. Then you build up into your strength, proprioception, into your cardio work to begin with, basically on a bike initially, and building that cardio up to more core stability and functional training drills. So that enables you to get to end stage. And that functional drill, that neuromuscular control, is key to moving into end stage. And that is what we're all looking for. And that isn't time dependent. It mustn't go on time, it goes on performance. So the things that you need to take into consideration before going into end stage are the fact that, were there any predisposing factors? 70% of all ACLs are non-contact. So there may be underlying factors you need to address, and they must be done before you go into end stage. So biomechanics or proximal stability or anything you feel that predisposed that to the person to that injury. The other things you need to make sure, full range of movement, no swelling, no pain before you go into end stage. Also take into consideration the graft type. Now, if you've got an allograft, which is a donor tendon, you need to think about time, longer to integrate, cellular repopulation, revascularization. Take your time before you enter into end stage. That also applies to under 19s, because you're going to take them through 12 months and not 9 months. And also the hypermobile, making sure they can control their extension. So then what are we looking for in the end stage? What we're doing is we're stimulating the afferent information processing, stimulating these mechanoreceptors that are developing with your donor graft or in your graft, and all the ones around the structure of the knee. So it's important that at the beginning you work on high visual input, but through the end stage rehab, you want to then start withdrawing that visual input and store visual distraction, because in sport, you cannot look at your knee and feet to see where it is. So that's important, working on surface stabilities, speed of the exercise, complexity of the exercise, and then ultimately the reaction time, so perturbation training at the end. So your 6 stages of ACL end stage rehab are speed and agility, number 1. 2, advanced proprioception, power endurance and cardiovascular ability. 4, jumps and plyometrics, looking at explosive power. 5, decelerative eccentric drills. And 6, your final one is the reactionary perturbation training. All this to be done before end stage.
Go on then.
Let's go. So, first one.
While you're getting ready, you say full range. What if you can't get full range? What if they've never had? Are you still going to go? Like they lose 5 degrees of end range?
If they've got a calm knee and they didn't have it before and the surgeon didn't get it in theatre, then I'm not going to get it.
Okay, perfect.
Right. So we're going to start with the agility ladder drill. So we're looking at quick feet, double tap each box all the way through. And what you're looking for is a slow ACL leg, and they're going to work on this. Excellent. And so you can see he's not injured and the leg speed was equal, but you will see an asymmetry, and they've got to continue this till they do it. Then we're going to do it laterally, 1 in, out, leading with the front leg. And what you'll see with ACLs is they will lean away from the leg. They won't want to go over it. You've got to get them to lean over that leg, leading both ways and getting left and right symmetrical. So then we work towards getting on the landing drill. So you're going to do a double tap in the box, and then we're looking at the landing. So making sure the foot is square, the knee is over the foot, and the pelvis is level. Towards the camera, once more. And hold that position. Making sure everything is in alignment. And so your proximal stability and your functional control is correct. Moving on from that, we work into the hop. So we're looking at the power of the leg here. So you're going to do 1, 2, 3, 4 round the clock. And so we're looking for a light foot here. We're not looking for a heavy foot. If it's heavy, they've got no power to weight ratio. And then you can do the lateral drill. So you go lateral, looking towards your return to sport testing, your 40 centimeter lateral test. 60 and 30 seconds is your target. And stop there. So from that, on speed and agility, we work to a T-test. So we're going to go right up here. He's going to do quick feet motion all the way to the stop, drop squat at the top, then move laterally to a landing drill, then laterally to a landing drill, and then back to a drop squat and back. And you can make that more complex by doing a crossover and touching the cone. So that introduces more complexity, more loading to the knee. So then from that, we would go to the W test. So where you run from here, you touch the cone and back. And again, loading, leading with the ACL leg to the lunge, there, and back. And then the center one, and back. Okay, and that's great. And then over from that, we can then work into adding load to that by using a bungee. So this is great if your clinic is small, round the back, and you don't have much space. This enables you to work at speed and at load. So we'd repeat that drill. I'll just fold it around, it's fine. Yeah. So he would then run, and you can lock off the load, and you can add load to him. And he comes back, he's got to do a bit of eccentric control, and back. And again, move, and he's back. So you can add, again, this is increasing the complexity. So then if you think you've got him right up to speed, you can do overspeed training. This tends to come a bit later on. This is hard on the hamstring. So with overspeed training, if you go to the back of the room, yeah, keep that on. What you're going to do with a bungee, you're going to assist and unload his body weight so he can work on leg speed. Knees up, knees up, knees up. That's it. So he's working on speed. And again, so you add load into it, and then he's going to stop, okay? So that would be where a selection of speed and agility work, and you can increase the complexity. You can start throwing a ball into certain situations as well for visual stuff. So from speed and agility, we go to advanced proprioception. Now, I like to use the Bosu here. So first of all, he's going to get up there and just do some tempo squats and just pushing out and work on what his knees are doing. Where are his knees? Are they over his feet or are they going into valgus? Making sure it's staying level, he's not dominant on one side. Then he's going to do ski squats. And this is a great exercise, staying down nice and deep, driving those legs. This is a nice little warm-up drill. Good, and down. So now he's going to do a running man. Now this is where you get good functional control. And to make that more difficult, you chuck a ball in. So he's got to now visually distract. He can't look at his feet. He can't use the mirror. He's got to think about the ball. And that's where you progress your exercises. Okay, so following on from there, he's going to do a lunge onto the Bosu. That's it, and back. And then onto it again, looking at his knee control, his pelvic control, and you can then get him to lightly jump onto it. And then we can do it laterally. Again, with ACLs, they don't like going lateral, and you're going to look at that control of the knee. And then we stop and we put the bungee back on. Face me, turn around. And what are you going to do there? He's going to get onto the Bosu. Stop there, stop. You're going to jump on with both feet. So you're going to have to land and hold. Go, yeah. And back, and again. And you're adding resistance. And then this time he's going to run on it. So you're going to put a bit of tension on him. And he's got to go, he's got to go, he's got to go, he's got to go, he's got to go. And then back again, yeah? And you can get them running onto it, okay? So that's, as you can see.
What would you do without a bungee if you don't have a bungee? Because all of this is relatively cheap, Tom, isn't it? So
yeah, well, one of these.
Bands, yeah?
These pull-up bands we use, and just loop them around.
Chips, yeah.
Cheap as chips, yeah. Decathlon, there's a quote for you. Okay, so visual distraction is also good in this event here. So throwing balls in. The next one was power endurance. We can't demonstrate that today, but it's like isokinetic testing, high speed, looking for fatigue index. Your biggest nemesis in ACL reconstruction is fatigue. 70% rupture without contact, that means the muscles fail to control the joint. So fatigue, power endurance, you'll see they're good at the beginning and then they fall off a cliff. So circuit, spin classes, running, doing suicide drills, that should be part of your process. Once you've gone through that, we then looking towards plyometrics and jumps. This is where it gets interesting. Sometimes, if you put the band on around your knees, sometimes you're going to get a degree of apprehension. They're going to look at it. They're going to look at it, and they're going to keep staring at it, and they just don't know what to do. You've got to then convince and land. With the band on, he's got to drive his knees out, working glute med a little bit. And we've got to do it ninja style. Ninja style means no sound. So he's absorbing eccentrically through his quads. And now take the band off. And now he's going to land on one leg, which would be his ACL leg. Jump and two-leg landing, that's it, there. Now, looking at that knee there, watching it stays level and straight, excellent. And again, slightly valgus on that one. So you would then do it laterally. So you jump sideways and down. And then you're looking at landing drills. Yes? Keep. So when you're looking at landing drills, if you then use this and jump off this, okay, you're going to think about sport and a bit of contact. So you get him to jump from there, on there, like a trampoline, into me and land on your legs, facing forwards. So you add a little bit of contact, because it's not all lovely in sport. You can't just come out of the gym into contact sport. And a little bit of contact, looking at his landing, and you can do it on one leg too. And again. Okay? And then you put a combination in. Okay? So you want to start making complex maneuvers, just like in sport. So down we go there. This comes out. Down a bit further. So what he's going to do, he's going to drop down to a pure plyometric leap onto here, hold, down, and then land on one leg. Up, hold, down, up. Good. And then to make it more difficult, you add a rotation in there. So a 90 degrees rotation at the end. And you throw a ball in. So suddenly he can't look at himself. Okay, let's try facing me this time. One more. Yeah, so, and sometimes you find the athletes are actually better when they catch a ball than without. It's more natural for them. So that's what we would do with jump and plyometrics. Then we get into decelerative mode. Now, this is where a lot of ACL patients start to panic, because this is mechanism of injury. Okay? So they're usually decelerating and rotating. So all I want you to do is just jump onto the ACL leg and back. So you add load, and you can really feel his quads, and you're looking for what he's doing with his leg and how good it is. And you add that extra. You can angulate it, and you can pull him offline, and that is a really good exercise. And then from that, you can run and stop. So if we put the bungee back on, you can do it without the bungee and just running in. So decelerative drill. So if you go to the back of the room, and he's going to run towards me, and he's going to stop on his leg. Yeah, and again. And run and stop. That's it. And you can put an inclined step there to make that stop even harder. Okay? Good. And then you can start doing a little zigzag. See it on? Yeah. So go to the back of the room. So he's going to do a little side step. And this is where you've got to take your time. Not too big at the beginning. Yeah. Okay? And let them get confident. And now I want you to do it backwards. So turn around. Yeah. So yeah, go out there. And now do the same thing coming backwards. Really working hamstrings and keeping that alignment. Okay? That's that. So, how are you doing? Yeah, we're doing good. The last one now, perturbation training, reactionary drills. And you can get these reaction balls that work really well in big spaces, and you can throw them and catch them, and they just work off different directions, yes? And you can work with that and have him running at speed and throwing it. But the one we want to do is something like a shadow drill. So with a shadow drill, he's going to be one side and I'll be the other. And he's got to work out which one I'm going to touch. So I'm going here, going here. I'm going to touch that one, and he's got to beat me to it. Yeah? And so you can have him on a bungee doing that as well. Okay. Make it more difficult. Okay. And the final one we will do is one more bungee one. And this reactionary drill, this is what sport's all about. It's not premeditated activity. So he's going to turn around and he's going to touch one of those cones. But in the meantime, while he's waiting, he's going to be doing a quick feet lateral drill here. Sideways, sideways, and yellow. He's got to go to yellow. Come back. Sideways, sideways, quick, quick, quick. Orange, orange, orange. And back. And white, 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 white. So you can't, no premeditated exercise. Okay. And that's how we would finish. And only after that can you do to your return to sport testings.
That's really amazing.
That's a lot in.
No, obviously you don't do it that fast.
No.
Well done, Andy. So look, a couple of quick questions. I know we haven't got much time. Would you say someone who's not able to do that, obviously not at that pace,
yes,
shouldn't be having an ACL reconstruction?
Well, it depends what they want to achieve.
Okay. So would you do that level for someone who wants to play social tennis?
No, absolutely not.
So it's sports.
You've got to think about who you've got. If you've got a 6-year-old who goes skiing once a year and plays golf, you're not going to do plyometric drills.
But what I'm saying is maybe he shouldn't be he's the one who shouldn't be having an ACL.
It depends how unstable they are.
Okay. And at what point do you, obviously this is your expertise, I know you do end stage for both of you, this is what you do. Do you see patients, are you nervous sometimes, or would you just stop them if you any doubt in your mind and they're not ready?
Always. It's not on time, it's on performance.
Correct.
And you've got to wait till they're ready. This can take 12 months or more. Somebody can't get it. 82%, there was a study in Australia, 82% of ACLs did not finish end-stage rehab.
Correct.
So that's why, potentially why re-rupture rate is slightly higher than we'd like it.
And absolutely, and I don't believe that most people do it.
No.
Okay, patients we might see might, but not all of mine do, definitely. No. And it's difficult because people will be watching this going, geez, I never did that if they're patients, or I don't do that with my patients. All this is will be on the Össur webinar, this on my Instagram live, and the guys will post this so you can watch this back. And as I say, Tom, Activate Rehab, if you DM him, he'll send you some slides. Thank you both very much. Okay, so next is Damien Kelly, who again is a specialist in elite sport, trained in Ireland, went to Munster. He's looked after elite rugby teams for most of his life. He's working with Formula 2 and Formula 1 teams, and he runs physical health
fast
in Bagshot. And he's going to talk about
ridiculous.
my athletes
Thank
ready
you, Andy.
to play after a knee injury, not just ACL, but all knees. Thanks, Damien.
Hi, everyone. Can you see me okay and hear me okay?
Yes, all good. Thank you.
Okay, brilliant. Okay, so hi, everyone. Thanks to Paul and Össur for having us here. It's been great to see some of the talks so far, and hopefully I can keep up with some of the rest of them. My name is Damien Kelly. I'm a physiotherapist and director of Physical Health, which is based in Surrey. My background is primarily in sport, having been involved with Wasp Rugby and Bath Rugby for the last 8 years. And more recently, while doing clinic this year, I've been supporting a Formula 2 driver who's also a test driver for Mercedes Formula 1. So, so is my athlete ready to return to play? A lot of the thoughts and processes I'll be sharing are based on my experiences within rugby, given that's where I've spent my career, but they can be used with any athlete in any sport. So hopefully you'll come away with some useful ideas for your patients, whatever knee injury that they have. So when I think about return to play criteria, I immediately think of those objective testing protocols that are out there. There have been some big strides made with research-backed tests, such as your HOP test has been spoken about before, isokinetic testing, and different types of running tests as well. So these give you some cold hard numbers to support your rehab planning and return to play decision making. At the end there's one about time. So that's based on the Grindam et al. Study in 2016, which said that for every month that you delay your return to play, you're potentially reducing re-injury risk by 51%, up as far as 9 months. So that's sometimes involved in the criteria as well. So many of these tests I would have used in the past, and also as a good resource for people, that Melbourne ACL Rehab Guide 2.0 is a great resource. It has good stuff for patients within it, and a good kind of testing protocol section at the end as well, which is worth a look. So testing in general, is it a friend or foe? As always, we need to be cognizant of the evidence, and probably unsurprisingly, there's reviews, they're quite mixed really, the results of them. But for now, all these tests are all we have. So we want to try and, there's a bit of a gap at the moment between that testing protocol or those testing protocols, and that probably reflects the gap between the chaos of live sport and doing, say, potential hop tests. So as clinicians, that's our jobs. We want to fill the gaps and provide stresses to the athlete and their knee that will enable them to overcome their knee injury and ensure that they've both the ability and the confidence to perform. So how do we bridge that gap then? We want to solve those some athletic puzzles. This is a term from Bill Knowles, who's a rehab specialist in America. That's referring to moving comfortably and regaining that movement literacy. We want to analyze and identify as many of the specific demands of that sport as possible so that we can recreate these for the athlete and give them a chance to adapt. We can put these together in gameplay scenarios, which I call sometimes worst case scenario, and this will allow them to perform these demands under fatigue, recreating that worst case scenario that they might come across. And finally, before considering them ready to return to play, we need to know that they're mentally feeling good and ready, and that they're confident to perform. So, just waiting on the next slip. There we go. So I think Bill Knowles' concept of solving athletic puzzles does a great job of filling the gaps between the criteria and return to play. It gives the nervous system space and opportunity to relearn movement and restore confidence, just like we used to do as kids, really. So we start with some very simple movements. As you saw there was bear crawls, hops, and even rolling and jumping, just like any kid would do in a gymnastics hall. And it's also a great place using a sprung floor. It's a great place to start these types of exercises because the ground reaction force is less, and it gives the athlete an extra bit of spring to help get them moving again and improve their confidence. So this all helps prepare the athlete while they're addressing the injury, not the other way around, which is pretty important. You want to be addressing the whole nervous system, not just the knee. So I should say that if you don't feel comfortable using these types of exercises, just be as creative as you can. Use some of the ones that Tom has used as well, and just make it interesting, challenging, and enjoyable for the athlete. Just remember, if you're not pushing the envelope, then are you potentially doing your client a disservice when it comes to their return to play? So this wasn't part of my rehab program, but as you'll see, the restoration of confidence, this is after a PCL injury, the athlete, just by doing these exercises, starting to regain that confidence that he has naturally and regain some of the ability that he has naturally himself. So I had nothing to do with that, but I think his confidence, it shows that his confidence was improving well. So another way to bridge the gap then is we want to bridge that gap between the rigid return to play tests and the unpredictable nature of live sport. So what we want to do is analyze the demands. And traditionally, picking basics like running, tackling, kicking is probably not enough if we want to fill all of those gaps. So what we can do is analyze it in more detail. So getting to this point and this kind of detail gives us a chance to cover loads of different types of aspects of what they'll need to be successful at when they return. And as a result, the knee gets a chance to adapt, the athlete grows in confidence, and as a clinician, you're confident that when they've returned to play, they won't have much thrown at them that they haven't already completed before. So as an example, in the professional setting, we're lucky sometimes to have GPS, and this just gives you an idea of the kind of detail that we can go into. So we can see that in each training day of the week, we had a guide basically as to the average running distance, how many meters that would be covered at different speeds, and even how many accelerations and decelerations were covered as part of their different training sessions. By adding this to total match data, we were able to get an idea of their weekly load, and that helped us plan back from there so that we can get a step-by-step progression of their rehab to be able to match what they need to be able to do in a normal training week. So it means that what we can do in a clinic environment when we don't have GPS available, if we sit down with the athlete and potentially their coach, get as much detail about what a session means for them and what it entails for them, it helps us take step by step back when we're planning, and we can build back up to that point in a safe manner. So now we know what the demands of the sport are, and it's a case of trying to bring the athlete through increasingly difficult or increasingly challenging tasks. The first one here is just going from a basic acceleration to deceleration. We have some change of direction. The first one is planned, where the athlete knows where he's going, and then some reactive drills where the athlete doesn't know where he's going to have to go, But again, it's something that he will have to do on the pitch, in this case as a winger in rugby. So all the time we're also inputting some speed work. So when he returns to sport, he'll have covered enough high-speed meters to reduce his injury risk of soft tissue injuries. The tough part with these isn't so much picking the exercises, but about knowing how many of each exercise to pick. So for example, changes direction, acceleration, deceleration. If we can be as specific as possible with our planning, it means that we get a nice progressive load and reduces injury risk when they return. So when they're comfortable with these individual tasks and their knee is staying nice and quiet, we start building these drills and start putting them together. This can be in gameplay scenarios under fatigue. This can be against opponents or even yourself if you're feeling very brave. We're getting closer to that worst case scenario. So if we know that a player has, say, in a 20-minute period, might recreate 10 tackles, 10 carries, and covers a certain amount of distance, we can try and recreate those scenarios within their rehab so that they know that they're good to go when they finish all these. In practice, in a clinical setting, I would consider asking them to bring a friend along or a teammate so that they can practice these things, and it just basically increases the enjoyment, but also how relative and realistic it is for their whole rehab processes. So last but definitely not least, is the psychological aspect of return to play. It's a neglected area, but now it's well recognized. For example, in 2019, there was a review where 795 patients didn't return from their ACL injury. 65% of these cited fear of re-injury and other psychological issues as the reason why. For the people that are more and feel more ready to return, they're obviously more likely to return to their pre-injury level, they return to play faster, and they perceive superior performance on return to play. These are a few examples of different return to play questionnaires or readiness to play questionnaires. So it doesn't matter really which one you pick, but the main thing is that it stimulates a conversation, and it's a tool that basically it helps you get an idea of where they're feeling mentally. Even if physically they're taking off everything very nicely, then if something comes up poor in this result, it stimulates a conversation and might uncover something that you wouldn't have otherwise seen. So it's just as important as any physical test. So now we've worked hard to try and fill the gap. We not only have a dry, quiet knee, hopefully, we've met our functional markers. We've solved some of those athletic puzzles from earlier that we spoke about, so they have their movement literacy back. We've ticked off some of their speed, endurance, strength, and power markers that should be required for any type of knee injury. And their previous injury history is catered for. So there's no point rehabbing a knee when they have other injury history to be trying to cope with as well when they return. Their skills, we need to make sure they're ticked off. You can include a coach if needs be. And is the athlete mentally ready and happy? There's no point trying to do any of these physical things if they don't feel confident stepping back onto the pitch. So thank you very much for listening. I hope it didn't go too quickly. Obviously, there's a lot to cover there. If anyone wants to chat through the stuff further, I'd be happy to chat through. I'm always happy to talk about different approaches with a knee rehab and any other type of rehab as well. So happy to answer any questions or see if Paul, if we have time or not. But thank you very much.
There's just one question, Damien. Thank you very much for that. It's just asking what your criteria for quadriceps index would be before starting these intense rugby drills.
Before starting those, so I would make sure that you've passed a lot of functional tests. So all of these intense rugby drills are based on the fact that you will already probably passed your hop test markers. Your single leg squat is for endurance and reps is similar to the other side. And you're reaching your max torque or your max strength markers from pre-injury as well. So it could be a common one to use is 1.5 times your body weight on a double leg squat. And then if you want to go to single leg variations, you'll be trying to get within 10% of your other side. So I would say before you're getting onto this rugby type or high-end rehab, you want to have all of those basic return to sport criteria ticked off, those special tests and those strength markers. And then what this does is bridge the gap between that and actual return to play.
Okay, great. Thanks very much.
Damien, just brilliant. Thank you very much.
Thanks.
And I am just gonna do that. Have you got my screen?
Yep.
Very good. So I'll just get a quick few minutes before we do the OA knee demonstration. 2 seconds. Okay, so that's that. Don't worry about that. Was for the ACL, but we haven't got time. So the incidence of OA is going up all the time, and half of all OA consultations are for the knee. And as Ben Steele-Turner alluded to, the obesity rate is going up as well. We know about the education advice to strength and the weight loss and nutrition advice we do. But what about this exercise prescription? Aerobic exercise, reduce your weight, improve your cardiovascular health, flexibility, maintain or improve your range of movement, reduce stiffness, then get strength, but with muscular support, reduce your maltracking and absorb your impact. All these are designed to maintain function and joint preservation. So in summary, OA, treatment, rehab. Surgeons are very poor at this, very poor at the use of braces and painkillers. We're good at injections and we're good at interventions, but we should wait for a knee replacement. A few myths of OA: increased strength, quads VMO. Take it easy, and flexion contracture is fixed. Increased strength, no, you've got to get motion back, then the pain down, then get the strength. You can't strengthen a stiff knee. Adjust lifestyle, take it easy. No, completely the opposite. The pain gets worse if you don't do the exercise. And fixed flexion deformity is not fixed. It can be reversed. It takes work. And Tom Williams is going to run through this with Paddy in a minute. You want to try and aim for symmetrical extension. We do not see full extension at the time of knee replacement. Patients with good extension have less pain. We need full extension for the VMO to function normally. Arthritic knees with a good range of movement do very well. And what about braces? Obviously, Össur are helping today. We've done some work on the unloader, and we know that if you unload the compartment that's affected, you can recover the joint space. Lee, Briggs, and Kirkley have all published on the Össur unloader, and at St. Peter's, Oliver Welsh and the team have produced a paper on brace before you replace, where we looked at 509 patients over 5 years, 83% with grade 3 or 4, and 80% did not go on to joint sacrificing surgery. We looked at the cost. We have saved saved 141 cases a year, which equates to close to £1 million of saving in one trust. And the reason we look at this holistic approach is because knee replacement is a good option, and Mr. Rajaratnam will be talking about this, but the literature suggests that only 10% are extremely happy, 80% are happy, but there's this worse or not happy group between 10 and 15%, and that's what we're trying to reduce. Okay, so we're going to stop there and go to the main camera, and we're going to get Charlie and Tom in. Hi, Paddy. If you just pop yourself on the bed. So what I want Tom to go through is, Paddy's a patient. Paddy is 73, he's a golfer, used to run golf clubs. He doesn't want a knee replacement. He came to see me, doesn't want a knee replacement. He'll try everything. Painkillers, physiotherapy. You've done the brace, that works really well for you. So that's the medial unloader. He's varus, and Tom will go through this. So Tom, run through in 10 minutes your assessment of how you manage a fixed flexion deformity and an arthritic patient who doesn't want a knee replacement.
For me, you've got to break the OA cycle. The OA cycle is really important in terms of unloading the targeted loading that you can see on his medial compartment because he's slightly varus. If you can unload that, you will take his pain away. You take pain away, you can get muscle activity. But the one thing that steps in the way of that is if you have a flexion contracture. Now, for me, as you can see, he has a degree of flexion contracture. There's certainly no hyperextension.
Wait,
now,
can we get him a bit more comfortable? Let me take that microphone. Put your head back. If you shuffle down the bed, it just looks a bit sore.
Okay.
I don't think you need it.
So my job would be here, when we look at a knee like this, we'd start how much range of movement he's got into that extension. Then we go into flexion, and we see how much he's got. And I'm looking for what a soft end feel. If it's a soft end feel, that's really good, especially in the extension. You don't know if he's got osteophytosis that might be blocking, but the likelihood is that you can, if it's a springy end feel, you're going to get something out of it. So with Paddy, you can feel his pain would be medial joint line. Is that correct?
Right.
Like where I am here now. And then if you, assessing for the unloader brace, if you relax a little bit, let the leg go, and you can correct that varus. So therefore the brace would work. So when we're pushing down, is your pain at the front or the back? It's in the front when I'm pressing down. Yeah. Yes? Okay. So you would try and release these fat pads. You would look at the fat pad inflammation. You'd also look at the patellofemoral joint, and you can see this is quite restricted in terms of mobility. 50% of its width is what we're looking for. Okay? So tight lateral retinaculum, tight quads, and you would work into that. So I do a heck of a lot of soft tissue work into this and into his posterior capsule, and start to reduce the dominancy of his hamstrings and reactivate his quads. Without full extension, you're not going to get VMO. So I'd spend a lot of time working on that extension, and you can use various techniques, blocking, putting weights on, and holding. And that's not how hard you press, it's that you need to sustain that amount of pressure, which is medium pressure, so he can feel it and tolerate it. You're looking for the muscles at the back to fatigue. The stretch reflex to fatigue, and it'll allow it to creep in, and suddenly he starts to move into extension. Once you've got that extension, and you can use straps and all kinds, and there's machines out there that you can crank up and increase the extension, okay? He can then, if he tends to use this position, you can now use this as an exercise. So once you've gained the extension, then you do your quads work, not before. So once you've gained your extension, if you now lift this leg, what happens with this one? You push down with it, don't you? Yeah. So if you weight this one, he automatically has to drive into extension.
Yeah, very
so
good. Yeah.
You lift that for me again, and he's really having to fix through this leg, and that's the easiest one to do. Okay? You can do prone leg hangs with weights off the end of the bed, so he's lies on his tummy and he put weights on his ankles. That also assists. But manual treatment is the way forward for this, and work really hard. So once you've achieved your extension, some of the exercises like activating medialis by trying to get him to lift his heel whilst pushing down with his knee. And you will see this muscle start to activate once you get that terminal extension. And you're trying to get that maneuver. And so on his other leg, he can do it. So that's it, and relax. So the knee goes down, the ankle comes up, and he can see here VMO. That's what he can play at. You can use mirroring, and you can use biofeedback, muscle stim, like you've had the talks earlier. Okay, so in standing, so once you've got that, and it's achievable with Paddy, because that's a good soft end feel, up you get, Paddy. We'll go through the exercises. So for me, standing knee extension is a really good exercise. You go face on, face me, Paddy. That's it. And put your foot through there for me. Okay, so this goes around the back of his knee. Stand square like me. And all I want you to do with this leg is just lift your heel for me, bend your knee forward. That is your start position. So for Paddy at home, he ties this round his banister at home. It's quite straightforward. Put a towel behind his knee, make it more comfortable. Now drive the heel down and extend that knee fully. And then now do you feel that? Yeah. And then release. So you're driving into the extension you've achieved in your treatment. And again, work right back into it. Okay? And back. And this is one of the best exercises, I think, for maintaining the extension. Okay, good. There's also, off there, you can also then use a soft ball behind the knee against the wall, and he can then push into the wall, into extension. So you're squashing the ball into extension. Again, getting VMO active, that's our key to all this. Cycling maintains the mobility of the joint, keeps it nice and loose. You might want to warm up with that first. So other drills would be a step-up drill. Okay, so we'd use a small step that we could do. This one here, that will do, just that. Okay, so a small step. And we're going to get Paddy. That's not a step. Put two on it. Okay, Paddy, can you do a step onto there for me? Yeah, sure. So let it fold underneath me. Okay, can you step up onto there? Okay, so when he steps up, I would like him then to drive his unaffected leg up in the air. So when we try that, it's called an athletic step. You ready? Right, yeah. So left foot drives up in the air. Up you go. And that forces the knee back into extension. Okay, and this is a bit high for Paddy, I must say. But we would then drive that knee into extension, and it really helps them feel that locking mechanism.
Fold that grey underneath.
Okay.
Leave it up.
Don't worry. Okay. So that's the mechanism we would do there with that. You can do straight leg raises with ankle weights as well, but really working into the dynamics of terminal knee extension is what we want.
Okay. So I've got some questions now. So Paddy had painkillers, he's had an injection, he's had an unloader, so he's done, and he's had good physio. Where do you try and do the exercises first? Where's the role for injections in you in terms of just straightforward painkilling steroid?
Yeah, it's all about a combination, isn't it? You can't just do one thing or the other. And I think if you can go early with the injection, so you can go hard on the knee on the soft tissue work and get that extension back. You could do oral anti-inflammatories as well. But I think it has a massive role to play in what we're doing, because we're trying to change something that's been there for multiple years. This isn't recent development. So I think the drugs do help, and injections have their place for sure.
And what about, so look, Paddy's varus like me. At what point, so with the varus knee or the valgus knee, at what point, I know you're an unloader fitter as well, so when do you introduce that? Do you get range of movement first, or do you get the unloader in early? When do you get the bracing?
Get the unloader in early, because it's all about pain inhibition, arthrogenic inhibition. Okay. You're not going to get the quads if you've got pain. Okay. It's simple as that. So either get the injection or the brace. Get the brace in early. So then when you get your extension, like we were talking to Paddy earlier, it's when he drives into that extension, that's when the brace really works. It really opens up that medial compartment, and then for him, he's pain-free. So all the exercise you're doing with the brace on is then effective and not inhibited. So the brace has to be at the earlier stages, not the later stages. And as I say, it's a combination. You can't just do one thing or the other.
Are you playing golf in the brace?
Yes.
No problems?
No, no problems, but I think I haven't been driving myself enough.
Okay.
As in
extending.
Stepping.
Yeah.
So I've put the brace on and limping.
Yeah. But now you're going to be a bit...
Yeah. This is having said that, I'm 100% better with the brace on than I was before. I mean, I couldn't turn to play golf.
Okay.
I'd lost confidence.
And what are you now, 6 weeks into the brace? More?
Yes, 8 weeks now.
8 weeks. So what would you say in terms of timing? Would you say ease off after 3 months? Do you try?
What I generally say is that you wear it for the majority of your upright day to begin with. Get that sensitivity of the joint down so you can start to load it. And what you'll find is when you start to take it off for social activities and things, it buys you time pain-free. Okay. But if you were playing golf, no, he stays in it. Yeah. He stays in it for golf and long walks and hikes. But then that buys you time for social where you don't need to wear it.
Okay. And what was I going to ask? Oh, the exercises. So Paddy had a 20-degree fixed flexion deformity.
Wow, that's brilliant.
So he's done really well to get to where he is. But how often does he have to keep doing the exercises? Will that fixed flexion come back if he doesn't continue the exercise?
Unlikely. If his gait has been changed correctly, he will be driving into extension on most of the majority of his gait patterns. And also we do things on the stairs where you drive up, and he remembers these things he will do just on a daily basis. He doesn't have to do a formal exercise program, because once you've got him back to his golf and his cycling, that's going to keep him. You're not going to lose it.
Correct. And you're motivated. The thing is, people forget that patients are motivated to avoid surgery.
Oh, absolutely.
But you find quite the opposite sometimes. You'll see patients who go, I just want it, you know, and you know.
There's this misnomer that the knee replacement is a panacea of all, and it's going to fix you.
No, well, it's good in some patients. And on that note, we'll go to Sam and we'll see what he says about knee replacement. Thank you very much, both of you.
Pleasure.
Okay, so if we go to the front camera then, and then, so the next speaker is Sam Rajaratnam. Is Sam ready?
Yeah, I'm here, Paul. Can you hear me?
Yes, good. So we're just going to flick to your camera while I introduce you. Sam Rajaratnam is a specialist knee surgeon at the Showen Clinic in London, where I also work. He did his fellowship in Sydney with me. And he is extreme. Well, there's no one more passionate about knee replacement surgery than Sam. He does about over 500 knee replacements a year, and he is as cutting edge as they get when it comes to knee replacement. So I've asked him to say, once a patient is ready to go to a knee replacement, What are they in for? What can we expect? Sam?
Paul, thanks so much for having me. Can you see my screen? I'm just trying to share my screen at the moment.
No, it's not come through yet, but carry on. Just share screen if you can. And
just let me know when you can see it, Paul.
I will. I'm still here, mate. Just click on share screen if you can.
It's not.
Oh. So if you just Giles here, if you pop back to Zoom, click on the green icon saying share screen.
Got it.
Click on PowerPoint.
How's that?
Off you go.
Brilliant. Paul, thank you for having me, and thank you to Össur for hosting the event today. Real honor to listen to all of the speakers beforehand and also to work closely with Paul Tricker, who I recognize as an internationally renowned colleague. Like Paul, we do everything knee related, and my passion really has been trying to innovate and improve the human knee replacement so that you get to the forgotten knee as often as you can. And I have developed a team that does this kind of thing, and we are now approximately 4,000 knee replacements down the line. You can see here that basically there is a big difference between the osteochondral defect on the left and an osteoarthritic knee. An osteochondral defect is a discrete hole in the cartilage surface of the knee, whereas an osteoarthritic knee is basically multiple contiguous holes rubbing on each other and causing pain. And you will see from this MRI image that the pain in a knee comes from a number of different sources, from the exposed bony surface exposing the bone and irritating the nerve endings, to the macerated meniscus, which extrudes out of the joint and then gives you pain around the ligaments rubbing on the side, and meniscal tears. And don't forget that a failing knee surface then produces fluid, and this pouches very often through to the back of the knee and forms a Baker's cyst and gives you pain around the hamstring tendon. Knee arthritis comes in a number of different patterns, most commonly the varus bow-legged pattern, which is very painful, and you can see this as bone-on-bone osteoarthritis on that X-ray on the left. But don't forget the valgus knee. This is the same patient with the X-ray on the left-hand side looking pretty normal, and the X-ray on the right shows bone-on-bone on the Rosenberg or Schuss view. And so this epitomizes the fact that the valgus knee is a disease of the flexor surface of the knee joint and not the extensor. So very often will present in your clinics as giving way of the knee. Remember the patellofemoral joint. There is no cartilage behind the patella, and this patient will complain of pain going up and down hills and stairs, but they can walk 100 miles on the flat. There is a huge epidemic of the worn out knee. We model in Britain and America that there'll be a 643% increase in knee replacements by 2030, and that's not including the emerging countries and healthcare tourism. So what do patients ask us? Well, this is a meta-analysis which showed that over 25 years, knee replacements last a long time. But this is retrospective implants and studies based on 25-year-old implants. The manufacturing these days is very good, and I expect my patients to be have well-functioning implants for up to 30, 35 years potentially, depending on how they look after it. When do you do a knee replacement? Well, it's like picking fruit. You don't want to patient, and you've got to do all the rehab and the off, but equally you don't want to delay too long so that ligamentous instability and fixed flexion deformities and contractures have developed, because then you don't get a good result. So you have to pick it at the right time. Implants have improved tremendously in the last few years, They are mainly now surface replacements, both partial and full surface replacements, and they mimic the normal kinematics of the knee. On the left-hand side, you can see 3D printed jigs helping you with alignment. You can make custom-made knee replacements, and there are numerous philosophies on how you should align these. Mechanical and conventional alignment has been the norm for the last 20 years or so, but over the last 5 years, kinematic alignment, respecting the pre-operative shape of the leg and trying to recreate what feels normal for a patient, appears to show consistently better results. My philosophy on joint replacement surgery has been to mirror Dave Brailsford's philosophy, which is try and do 100 things 1% better. And as a team, if you form a team, you can then have remarkably good results. And this is Dave Brailsford on his recent quest to break the 2-hour marathon with Eliud Kipchoge. We've developed multimodal analgesic regimes, adductor canal blocks and infusions, numbing the saphenous nerve without a motor block, and we do a number of things intraoperatively. And we get all our patients walking at 3 hours post-surgery. So this is the norm. Everyone gets up, their motor block is worn off on their spinal, and they're perfectly comfortable to get moving. Cryotherapy reduces swelling and certainly helps with pain, as one of our previous speakers said, and I use it quite a lot. And the cutting edge of this is now moving into robotic technology, and we're just about to bring in the first commercially available ROSA from Zimmer Biomet into the Schön Clinic. And what this allows is for precision and for soft tissue balancing, to be precise. So it's not just about where do you put the metal implant. This is a soft tissue operation with some metal bits involved, and you want to prove that your soft tissue balancing and your kinematic alignment is millimeter perfect. One of the most exciting things about the technology is basically that that we are now able to, going forward, going to be able to look after the patient from end to end, because these companies have done exclusive arrangements with Apple and other wearable device companies, so we can work out exactly how many steps all our patients are doing from day 1 to day 30. Generally, they will go home the day after or 2 days after a joint replacement, but a nurse consultant can then monitor how many steps they're doing and then pick out the ones who are doing who are not doing enough. And so that's a very exciting juncture. Most of my patients are, this is a ex-England number 8. He is on day 9 after a knee replacement. And I would say 80% of my patients will go back to driving within about 2 weeks. So the days where people wallow in pain and that thing and functionally are very poor for 6 weeks is really, we're moving away from that through marginal gains. As the previous speaker said, pre-operative range of motion is the biggest arbiter of post-operative range of motion, and I like getting all my patients to about 130 degrees post-surgery. This is somebody at 6 weeks, and that is good. We monitor our results, and the National Joint Registry has been an amazing adjunct to all our practices, and every surgeon in the UK is one of these blue dots, and your results need to be between the 2 blue lines in terms of revision. So if you do something and you have to get it redone for infection, for loosening, for malalignment, your dot moves up. And if it does that, your failure rates go up. And you can see that there are plenty of people above the top blue line, which is the 95th percent confidence interval. And there are even some above the top red line, which is the 99.8% confidence. That's not very good. My dot is right at the bottom, and that is a very low revision rate on 1,845 knee replacements over the last 5 years, amongst the lowest in the UK. So you want to get it right the first time. The National Joint Registry also now presents data on Oxford knee scores and EQ5D scores, and again, here's last 10 years of work showing consistently positive outliers in Oxford knee scores. So it's all down to data, and you want to prove what you're doing really works and get people back to function. I leave you with this video from a patient from 2 days ago. This is a top hip surgeon colleague's brother who is making a remarkably...
I'm Charles Apthorpe. I had my knee replaced 3 weeks ago by Sam, and this is a story of my surgery and rehabilitation. I'm walking quite comfortably with no pain, very happy about that. A lot of flexibility to move up and down. Walking upstairs is quite all right, but I can try it. I'm just going to show you this walking upstairs. So difficulty at all, don't need to hold the handrail. Very comfortable. Very pleased.
So,
Charles,
so that was Charles, really sort of went back driving 10 days after a joint replacement, and is back working as a barrister within 2 weeks. So lots of advances, and Paul and I are interested in these marginal gains to get our patients better and back to function as soon as possible. Thank you.
Thank you very much, Mr. Rajaratnam. There's just a quick question. Is there a relationship between early weight bearing post total knee replacement and reduced range of motion? Does early weight bearing stop a patient from gaining near normal range of motion?
No, not at all. I mean, early weight bearing increases confidence, reduces DVTs and pulmonary emboli and that sort of thing. But I will say that the most important part of the rehab post joint replacement is capsular stretching. So I would say, please concentrate on getting range of motion back first, and then the muscles, if the patient is pain-free, managing their pain, the muscular recovery follows that. Extension, again, much more important than flexion. And I really like the previous speaker's emphasis on getting the knee straight and increasing range of motion before you start. So that soft end point before you start on a joint replacement, so important. Stretch that out. Give me a flexible knee and I'll give you a flexible knee back.
Sam, that's brilliant. Thank you very much. We did have to pause your video a little bit because of internet signal. So I just want to say thank you to everybody today. It's amazing. It's 7:01 and everyone can do their bath time, so that's good. Thanks for joining us. Thanks for giving up your Sundays. I'd like to thank all the speakers again who very kindly given up their time. Össur for making this possible again, and Prime Health for hosting us. And thanks again for joining us. On the Össur Academy website, this maybe next week or so, this whole webinar will be online. CPD will be posted, and please contact the speakers if you have any questions. And yeah, thank you very much for joining us this year.
Thanks, Paul.